We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 18 of AMOGS Emergency Obstetrics Committee with Rajkot, Palanpur, Surat, Vapi, and Valsad OBGYN Societies of Gujarat. So it's my privilege to introduce the convener of today's webinar, Dr. Archana ma'am. Ma'am is the National Chairperson, IMS Website Committee 23 to 25, President of BOGS from 21 to 22. I welcome you, ma'am. And it's my honor to invite Dr. Munjal Pandya, sir. Sir is the Treasurer of AOGS 2024 and also Associate Professor of Narendra Modi Medical College, Ahmedabad. I welcome you, sir. And I would like to invite the coordinators of today's webinar, Dr. Sarfaraz, sir. Sir is the President of Himatnagar OBGYN Society and also Director of Navjeevan Women's Hospital, Himatnagar. I welcome you, sir. It's my honor to invite Dr. Keetan Vyasa. Sir is the Consultant Director at Sevak Maternity and Surgical Hospital, Ahmedabad. I would like to hand over the session to Dr. Archana ma'am.
Thank you so much, Saidi. It's my honor and very privileged moment to welcome all the dignitaries on the stage at the same platform. And I would like to congratulate and thank Dr. Sneha Buyar, madam, for taking up this emergency obstetrics, which is a passion of all the hardcore obstetricians over here. That it is a great learning process, gradually going through the webinar and its topics. So hereby I welcome you all. And I would like to offer my prayers to God Ganesha.
Kurutvam kalyanam arogyam dhana sampadah shubham kurutvam kalyanam arogyam dhana sampadah shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam arogyam dhana sampadah Shubham kurutvam kalyanam arogyam.
Thank you, Saiti, for and with this worship to the God, I would like to open up the webinar for today and invite welcoming all the faculties, the star dignitaries, our guest of honors, and faculties from Rajkot, Palanpur, Vapi, Surat, and Valsad. I would like to introduce the brainchild of Dr. Sneha Buyar, madam, who was here for a continuous education trip for all of us. She is your candidate for Vice President Foxy Best Dome this year and is also was a Foxy Best Committee Chairperson and National Adolescent Trainer, National Expert of UNICEF, AMOGS Chairperson for Medical Disorders, Emergency Obstetrics. She had a mission for Pink Health Committee and convener of PCPNDT. I think we all know her. And the only thing is that this is a learning process at which she is the initiator of this program. Over to you, Sneha ma'am, to welcome all the dignitaries and give an insight of the program today.
Yes. Thank you so much, Dr. Archana. In fact, I would shorten my introduction just because we have Dr. Kiran Kurtakoti, the president of AMOGS, whom I would like to thank for the opportunity. And of course, I invite him for the welcome address because this is a AMOGS program. And of course, Kiran is a very dear friend, president of AMOGS. And of course, he was a past committee chairperson for MTP committee of Foxy as well.
That's okay, Sneha. Sneha, that's okay. Thank you so much.
Yes.
Thank you so much.
Kiran.
Yes. At the outset, warm greetings from the AMOGS platform. And I would really appreciate and acknowledge Dr. Sneha Buyar. I have been associated with Dr. Sneha Buyar for the past 25 years, ever since she was a senior for me at BC Medical College, Pune. And I have seen her working so hard, right from her postgraduate days till today. And I really hope, wish and pray that she achieves whatever target that she has basically as the Vice President of Foxy in this particular year. And I would appeal to everyone, to all my Gujarat colleagues and to all those who are seeing this particular webinar to vote wholeheartedly for Dr. Sneha Buyar for her current elections. Having said this, my best wishes I also acknowledge the presence of the chief guest, Dr. Suchitra Pandit, Dr. Sanjay Patel, and the shining stars of AMOGS as the guest of honors, Dr. Lakshmi Srikhande, Dr. Girija Bagh, Dr. Ajay Mane. So my best wishes again to Sneha. And of course, I also acknowledge Dr. Archana Devedi. Best wishes to you also, and to Munjal Pandya also. And coordinator Sarfaraz has been with us in Pune for the house conference. So I welcome on this particular platform. So also to Dr. Kirtan Vyas. And sometime I would request Dr. Sneha that she invites them all for the AMOGS conference in 2025 as the chairperson, speakers, and as faculty members. Also acknowledge the presence of Dr. Preeti Kumar and Dr. Vidya, who is going to be the expert later. So over and all, thank you, Sneha, for inviting me. Thank you for getting AMOGS on this particular platform. And once again, I would appeal to all of you to wholeheartedly vote in huge numbers for Dr. Sneha Buyar for the vice presidency of FOXI. Thank you. Thank you, Sneha.
Thank you so much, Dr. Kiran, for your wholehearted support always and your best wishes. Definitely.
One more thing. I also acknowledge the presence of Dr. Prafulji Doshi, and best wishes to Dr. Doshi because Surat is going to organize the presidential conference, and I would request all AMOGSians to go to the presidential conference in huge numbers. My greetings to Dr. Sanjay Patel. I saw him just now. Sanjay ji, namaskar, sir. And thank you, Sneha, once again for that.
Thank you so much, Kiran. A very good evening to one and all. Especially my respect and regards to Madam Suchitra Pandit, my mentor, and of course Sanjay Patel sir, who are the chief guests for today's program. Dr. Lakshmi Srikhande, the immediate past chairperson of ICUG, and a dear friend, Dr. Girija Bagh and Dr. Ajay Mane, the vice president of FOXI, the Pride of West Zone, as guest of honor for today's program. I welcome and express my gratitude towards the AMOGS President Dr. Kiran Kurtakoti, as I have already said, Dr. Bipin Pandit, and the entire team of AMOGS. Though my committee is mainly working in the field of emergency obstetrics, as you all know, prediction, prevention, and preparedness is the way to reduce the maternal as well as perinatal mortality and morbidity. So to go for awareness, predictive tests, preventive measures, and if at all you face such emergencies, tackling the preparedness to tackle. So we are working on all these aspects. And as you know, hypertension, hemorrhage, and sepsis, these are the three major killers of our women. Of course, anemia being the direct as well as indirect cause for maternal mortality. So we have included and invited Dr. Preeti Kumar to speak on anemia during pregnancy. Of course, Dr. Sanjay Gandhi, the past president of Palanpur, and Dr. Praful Doshi, the current president of Surat, as chairpersons, senior members of the Gujarat Societies. We are waiting for your valuable inputs. Of course, we have the panel discussion on medical disorders of pregnancy. So Dr. Vidya Tobi as experts, Dr. Lata Jetwani, Dr. Harsha Tandel, Dhwani, my dear, Sweta Patel, Dr. Kartikeya Shastri, Khanjan Maheshwari, Dr. Bhavesh Nayak, and all my esteemed panelists. I'm looking forward for the great discussion. This is going to be a very helpful webinar. And of course, my sincere thanks to Dr. Archana, Dr. Munjal, Dr. Sarfaraz Kazi, and Dr. Kirtan, of course, the president and secretaries of all the 4 societies. I thank all of you for gracing the program. And Saiti, may I have Madam Suchitra Pandit's CV? Having Madam as chief guest, who is my mentor over so many years, Madam, you know, all of you know Madam as past president of FOXI and of course the national president of ISOPA as well. And she has various awards and accolades, but to name a few, she's a FIGO Women awardee also, and so many other awards also she has received. Lots of publications to her credit, and Madam is still working very hard to strive also for the women's health. So over to you, Madam Suchitra Pandit, for your precious words of blessings and guidance.
Thank you, Sneha. As usual, it's a great honor and pleasure to be here at a program which is an emergency obstetrics program, which is actually the basic need of the country. And I'm glad that AMOGS has taken this up. And I think this year Kiran has gotten many societies. So congratulations to him also and to the entire team. And good that you brought this program forward and you're actually communicating with the Gujarat societies. And this gives us a, sort of a platform. I've been to these places before, Rajkot, Surat, Vapi, Valsad. But, when you actually see, because every year, there are going to be newer and newer people. So it's nice for us to also interact with them. And the topics that you've chosen, anemia, of course, is, the basics. And I think though all of us claim that we know everything about anemia, there is always something new that comes out of the webinar, and I'm sure Preeti is going to do justice to this particular thing. And your panel on medical disorders is going to bring out a lot of small things which are going to go a big long way. Let me tell you, friends, every webinar that I attend, I've always picked up something that I didn't know before. So I think if you keep your mind open, your ears open, and your eyes open, there is always something to learn. And I think that's also a good way of keeping your brain active, and also something which you can put into your clinical practice. So, with this, I'd like to say thanks to Archana for coordinating, and thanks to Sneha for inviting me. And Sneha, all the best. All our best wishes are with you, with Preeti, and Munjal. I don't know whether Munjal standing.
Not Munjal.
Because Kiran,
Yeah.
I know Archana is standing, but maybe Munjal, because he's helped with the co. But we're expecting him to come forward next year for some post. And of course, the coordinators, Dr. Sarfaraz and Dr. Kirtan Vyas. I mean, I've met these people also before, but lovely to see all of you, and all the best. And once again, we hope that you all contestants will come up with flying colors. And congratulations in advance to all of you. Thank you very much.
Thank you, madam. Thank you so much for your precious words, and it means a lot to all of us. Thank you so much, and over to you, Dr. Archana, to welcome and invite Dr. Sanjay Patel, sir. A very good evening to you, sir, Dr. Sanjay Patel, and we would like to listen to you.
Thank you, Sneha ma'am. I feel very blessed today by having all my mentors at one platform. Is really a thing which extra smile is coming on my face. And when I have to introduce Dr. Sanjay Patel, sir, he is a master in himself. I don't want to read what is written over here. He is a guru to most of us people. I think Gujarat, Pan India, I would say. I feel sometimes I've told sir, there are so many things to learn from you. Like Eklav, if you see him operating also, there are so many things you are imbibing. Sir, what else means your blessing is so important, and as a guru, naman to you, and please give your words of wisdom. You are excellence, par excellence. I don't have words to express for you, sir.
Thank you, Archana. I think you are the strong support for the Sneha, for the Gujarat. Everybody is knowing the Sneha. She is very hardworking, and it's very friendly with the entire part of the. Even though we look in the so many conferences, she is always with all the Guju people. And I think I realized that she is one of the part of the Gujarat. All the best, Sneha, for the particular this Foxy Vice President Conference. And I think my madam is also with us. I think our dear friend Kiran Kuttake, Suchitra madams, and Vidya Bhatt is also joining. Preeti Kumar is also with us. So I think this is the really, this is not my subject related to particularly on the obstetric side, but all the best for this wonderful webinar today. And I think you couldn't require any introductions for the Gujarat. Personally, I felt that because me and Archana Bish discussed related to you so many times. And even though now in the Gujarat, everybody is knowing the very well. Because you have so many friends, even though Kaji, Munjal, and every Sarfraz Kaji, Munjal, and everyone, those who I think young people, I think very, very close to the you. And these people is heading for the you. And all the best for this vice presidency of the Foxy. And whatever from our side, just let me know. I think it's pleasure for pleasure for us. Thank you. Thank you again, Archana. I think
what makes you say young? You're also young.
I'm forever young.
I couldn't declare my age, but after some time, look my hair. You realize that.
It's an aura, sir. The aura of your thing which we keep on learning. Thank you, sir, for the words of wisdom. I can see Kiran sir also smiling and supporting of whatever I said.
Yes. So thank you so much, sir. Thank you, sir. Sanjay sir, thank you so much. Your support means a lot to me. Thank you, sir.
And it's the bottom of our heart from the all, not from the my side, but from the entire Gujarat side. I think we supported wholehearted to the you. Okay.
Thank you, sir. Thank you so much.
Thank you.
Thank you, Sanjay sir, and it gives me immense pleasure to invite Dr. Tazi to introduce one of Dr. Lakshmi madam, and take the program forward. Tazi, you're on the mute.
Dr.
unmute
Kazi,
yourself.
please unmute. Unmute. Again. Unmute.
Yeah.
Yes.
Okay.
Tazi already complimented all gorgeous ladies here, so you are a chance to introduce the most
It's-
gorgeous person over here. Please go ahead.
No, it's really my pleasure to introduce Dr. Lakshmi Srikhande ma'am, the past chairperson of ICOG. So many awards under her name, and she has delivered 22 orations and 450 guest lectures. This is a big and huge number. Academically, she is so much active all over the India and the globe. Uh, 42 national and 21 international publications are there with her name, and the most last line of her CV I like the most. Sensitized 2 lakh boys and girls on adolescent health issues. I am so much proud of you, ma'am, and I am feeling privileged to introduce you on this platform. Another thing, national corresponding editor of the Journal of OBGYN of India, National Corresponding Secretary of Association of Medical Women in India, President of ISOPAB in 2019 and 21, Vidarbh chapter. She was also Chairperson of IMS Education Committee, Chairperson of Fertility Enhancement Committee of ISOPAB, member of Suffolk Education Committee, President of Association of Medical Women Nagpur, Senior Vice President of Foxy in 2012. We are waiting you for contesting for the President post in future, most probably President of Menopause Society and President of Nagpur OBGYN Society. Right now, she is a Medical Director of Sri Khande Fertility Clinic of Nagpur. Awards under her name is Nagpur Ratan. Nagpur Ratan. We can understand. You are not the Ratan of Nagpur only. You are the Ratan of India now. Received the Bharat Excellence Award for Women's Health and received Mehru Dara Hansotia Best Committee Award, and received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. Now the floor is yours, ma'am.
Thank you, Sarfaraj, for your generous introduction. And I will begin with Kiran. Kiran, as a AMOGS president, I must say that AMOGS सब जगह छाया हुआ है. You have really increased the visibility. There are so many academic and social programs going on in your tenure, and I can see all your committee chairs सब एक से एक बढ़कर काम कर रहे हैं, because that really add value to our association, that is AMOGS. So Kiran, hats off to you. And what to say about Sneha? Sneha, I know you since last 25 years. She's the queen of Yavatmal, and I know her obstetrics. She's really queen, huh? And a great academician. Today's topic, as Dr. Suchitra has already said, in India, we really need more and more webinars on this topic, and today is your 18th episode on emergency obstetrics. And I'm so happy to see Preeti, because who can speak on iron deficiency anemia than Preeti Kumar, because she has really done wonderful work in this field. In UP, she has launched many projects and she's actively doing work. So I'm so happy that you have chosen Preeti to deliver this talk on iron deficiency anemia updates. And of course, you will be moderating the panel on medical disorders, because nowadays we are seeing many and more high-risk pregnancies with medical disorders, which was not the scenario 10 years back. So I'm so happy that you are moderating a panel on medical disorders to update our dear members on this burning issue. Now I can see Vidya has logged in, and what to say, Sanjay has gone. Sanjay, I know you are the king of Ahmedabad. I am missing Munjal here. Sanjay, I am coming to Ahmedabad in October for ICOG conference. That time I will meet you. So Suchitra, nice to meet. And Who else? Girija. Where is Girija? Nice to share the dais with Girija, Ajay, Sanjay Patel, and Suchitra Pandit. And wish you all the very best to Preeti, Sneha, Archana. Who else is here contesting? You three. And I'm sure you all will be winners because openly everyone is supporting you. So we all are with you and we are looking forward to a grand celebrations during the managing committee of Foxy. Okay? Because I'm not saying in between. So all three of you, wish you all the very best for your endeavors, whatever you wish, you desire, may all your dreams come true. So thank you so much, Neha, for inviting me and making me a part of your this 18th episode of this webinar. Thank you.
Thank you. Thank you so much, Dr. Lakshmi. Thank you so much.
Thank you, Lakshmi ma'am. Coming from an academician like you is really a blessing, ma'am. So I think having Preeti madam and Sneha madam on this platform contesting and always inspiring all of us, we move forward to the, I think, Kazi, would you like to do the honors? I cannot see Munjal introducing another gorgeous lady, academician on the platform, Dr. Girija Wagh ma'am.
No problem. I am here only. It's always my pleasure to introduce all these stalwarts in front of this academic platform. Hello, ma'am. Dr. Girija Wagh, ma'am, is the professor and HOD of Department of OBGYN, Bharati Vidyapit Medical College Hospital. She is the senior consultant of Cloud9 and Apollo Hospital. She is attached with these two hospitals also. She is the faculty professor of OGASS International Expert General Coordinator 2016. She was the chairman of Medical Disorder in Pregnancy Committee of Foxy. She was the vice president of India chapter of Gastrosis, and she is the member of General Council of ICOG. She is the joint national secretary of Foxy 2010, assistant coordinator of National Eclampsia Registry, and she is the member of Central Supervisory Board of PCPNDT Act 2010 and 2014. She is the national mentor for Lakshya, NPOQCN, MOSFW, and GOI, and she got the Anand Bhai Joshi Award for Excellence in Medical Services. Now, she is also contesting for the Foxy. She is right now the Foxy Vice President.
Vice President.
She's
I have,
vice president.
yeah, Dr. Kazi, I have already said in my welcome address that we have Dr. Girija Wagh and Dr. Ajay Mane. Our
Ajay Mane is also the vice president. Yeah.
Yes. So do we have? I think Girija
Dr. Girija Wagh is not there now, I think.
She has just left for some emergency. We have Dr. Ajay Mane.
Yes, madam.
Yeah.
Welcome him. Dr. Kirtan Vyas is our. Kirtan, would you like to welcome Ajay Mane, sir?
Yes.
Good evening.
Yes, sure.
Thanks for joining with us. Yeah.
Yes. Doctor, it is my privilege to invite our dear friend and senior Dr. Ajay Mane, sir. He is the present vice president for Foxy in 2024, and he is also the state representative of AMOGS for 24 to 26 tenure. He is the member of National Inspection and Monitoring Committee, PCPNDT wing, Government of India, and he is a senior medico-legal consultant for last 18 years. The chairperson of official AMOGS website, Sexual Medicine Committee of Foxy chairperson, and also the Adolescent Health Education Committee of AMOGS. So he has so many laurels to his credit, sir. And he has also been the past president of Aurangabad OBGYN Society and ex-superintendent of MGM Medical College, Aurangabad. He has been a trainer in Foxy Adolescent Health Committee, a health advisor to the Sports Authority of India, and also the charter president of Rotary Club of Aurangabad Elite.
Yes,
so it's a privilege to have you with
sir.
us, sir. We welcome you, sir.
Yeah, thank you, Kirtan bhai.
Thank
you for those great words. It is very pleasurable to hear from our dear friends like Kirtan and Munjal bhai. So, respected Kiran, who is the president of AMOGS, Dr. Bipin sir, secretary, Dr. Rajan Singh Pardeshi sir, immediate past president, who is my mentor too. Then Dr. Madhuri, and our dear sister, Dr. Sneha Tai. We wish you all the best for your Foxy endeavor as a vice president. Foxy will be seeing you, Vice President Foxy, for next year with the help of all these stalwarts which are present here in this webinar.
Thank you.
And I wish my
every success to Archana Dwivedi madam too. The chief guest Suchitra madam, Sanjay Patel sir, and my co-VP Girja, and the conveners Munjal bhai and Archana ji and Sarfaraz bhai. I can see your white beard, but I don't know how you become such old in few months. I'm so sorry. He's my very good friend, so I just pulling his leg.
No, just it's lots of responsibilities. These all ladies given to me, na. You can ask Dr. Sneha ma'am.
मतलब सरफराज भाई बहुत थके थके से लग रहे हैं, मतलब थोड़ा सा टांग खींच ही लो अभी इनकी. चलो ठीक है. See, Dr. Sneha Tai is conducting so many webinars on various topics that I like about her. If I conduct any webinar, it will be on medical legal or emergency obstetric only. But she is the person who is conducting webinars on n number of topics. So Preeti madam and Lakshmi madam, they will say yes to my sentence, and we wish you all the best, madam. So the today's topics are again two different topics. Obstetric labor is there, then medical disorder of pregnancy. See, there are only two topics in this webinar. So she is a lady, a very academic person, and very what we can say that energy containing personality from Maharashtra and Gujarat. We are concerned, sister concerned states. So please help her. And I request Dr. Kiran Bhai to help her go there in Foxy, and all of you. And thank you very much for calling me here. Thank you.
Thank you, Ajay. Thank you for your best wishes, and thank you for sparing time from your busy schedule. Thank you.
I'm so sorry for joining late. Just I was.
So you are with the time. Thank you, sir, for your encouraging words for Preeti Kumar madam, Sneha madam, myself. I think it means a lot for all three of us. And it's a proud privilege, again, I would say, to welcome everybody on this dais, all my mentors together. So I'm very thankful to Kiran sir, Dr. Vipin Pandit sir, Dr. Arjun Pardesi sir, Dr. Ajay Mane sir, Dr. Suchitra ma'am, Dr. Sanjay Patel sir, Dr. Girja Wagh ma'am, Dr. Lakshmi Srikhande ma'am, and my co-societies from Rajkot, Palanpur, Vapi, Valsad, my right and left hand, I would say Dr. Sarfaraz Kazi, Dr. Kirtan Vyas, and Dr. Vidya Thobi is here. I acknowledge her presence. Dr. Praful Doshi is here. Dr. Sanjay Gandhi, we welcome you all. And without going further ado, let us start with the educator session. Over to you, Dr. Sarfaraz Kazi, to conduct the first session. Thank you.
Thank you, ma'am. So our first session of this webinar is iron deficiency anemia and pregnancy update, and I can say Dr. Preeti Kumar, none other than her, can give a full justice to this topic. For this session, our chairperson is Dr. Sanjay Gandhi. He is very senior to me, but he is always there like a friend whenever I call him for any help. Dr. Sanjay Gandhi, working in a Aarti Hospital, IVF Center, City Gem IVF Center. He has completed his MBBS and DGO from MPSA, Jamnagar Medical College. His IVF training was at Dr. Indira Hinduja and Dr. Colin Lee, Malaysia.
It is okay, Sarfraz.
Sanjay sir, you are the state faculty in IVF, and you have taken more than 30 lectures, and practicing since 28 years, and he has done successful mid-Sogog conference in Abu, which we have witnessed with full of energy and full of academics. Our next person is Dr. Praful Doshi. I would like to say Dr. Kirtan Vyas to introduce him. Dr. Kirtan?
Yes, sir. Yes, sir. Yes, sir. Yes, it's a privilege again to welcome and invite Dr. Praful Doshi, sir, as the chairperson for the session. He is a very senior practitioner from Surat, presently the president for Surat OBGYN Society. He is passed out from MBBS in 1981 from MPSA Medical College, Jamnagar, and MD from BJ Medical College, Ahmedabad. He has received diploma in advanced endoscopic surgery in Germany and training in IVF from the USA and Australia. He is the professor of gynecology at the Medical College of Jamnagar in Surat and a senior consultant right now at Blossom IVF Center and Me and Mummy Hospital and IVF Center in Surat. So it's always a privilege to welcome you, sir. And we invite both our chairpersons, Dr. Sanjay Gandhi sir and Dr. Praful Doshi sir, to go ahead with the academic session, which is to be conducted by Dr. Preeti madam.
Yeah, we can request Dr. Sanjay Gandhi sir to
Hello.
introduce Preeti Kumar.
Yes. Hello, Praful bhai.
Hi, Sanjay.
Welcome, both of you. Dr. Sanjay Gandhi and Dr. Praful Doshi, welcome.
Yeah, I welcome all
Dr. Praful.
participants. May I introduce Dr. Preeti?
Yes.
Yes, sir, you can go
Yeah,
ahead.
yeah.
Yes, please go ahead, sir. Please,
Yeah.
please, sir.
Today's our this topics she is chairperson in maternal and perinatal committee SAFO and chairperson in Safe Motherhood Committee FOXI. Committee member of MFM committee AOFOG and joint secretary of India Justice chapter. She is professor and head of department of obstetrics gynec Narana Institute of Medical Sciences Kanpur and organizing secretary in UPCO 2023 Lucknow, AICOG 2020, IAG 2018, and she is vice president of Lucknow Obstetric Gynec Society in 2020 to 2022. And there is a long list.
Thank you, sir.
Yeah.
Thank you.
Thank
Let's
you.
start the session.
Welcome. I welcome you.
Thank you so much, sir. Let me share the screen. Sir, are the slides visible?
Yes, ma'am.
Yes, madam. Please, please.
Okay.
Can I say for 2 sentences?
Yes,
If you
Ajay.
allow me. Yeah. Dr. Preeti Kumar ji is my elder sister. Particularly, I'm saying that. So, by the way, she is also contesting the elections of FOXI North Zone VP. So this year, I'm having 2 of my sisters as a VP. That is for sure. But it is possible only with the help of you all. So kindly help my 2 sisters go there in FOXI. Thank you.
Thank you so
very
much. Thank you so much, Ajay. Whatever you speak, it comes right from the heart. Thank you. So, respected chairpersons, at the outset, let me thank the organizers, especially Sneha and Dr. Kiran sir, for giving me opportunity to speak on this platform. And I'm very, very closely associated with most of the members of Gujarat Society, and I also feel as a part of the Gujarat Society. And I try to visit each and every conference which is held in Gujarat. So thank you so much. And for next few minutes, I'm going to speak on especially iron deficiency anemia in pregnancy. And I really want to express my gratitude to all the experts, the guest of honor, special guest and chief guest for their kind words and motivation for going ahead in FOXI. And definitely we will try to do our best. So there are certain changes which have happened in over past few years in iron deficiency anemia management. And the irony is that most of us are actually, as an OBGYN, don't know the exact, how to diagnose and how to manage anemia, the exact protocols for the management of iron deficiency anemia. Now, if you see the statistics if you see the statistics of NFHS 4 and 5 data, I would like to focus your attention on Gujarat. There had been increase in the prevalence of anemia in pregnant women from 51.3% to 62.6%, and there had been an increase of 11.3% over last, NFHS 4 to NHFS 5 data. Now, recent recommendations from the Ministry of Health and Family Welfare that to prevent from anemia, they have given certain recommendations like delayed cord clamping, switching over from 100 milligram to 60 milligram of elemental iron as a prophylactic dose of elemental iron for women and adolescents, and mandating use of fortified food in public health program, special attention on double fortified salt, especially iodine and iron. Invasive digital methods wherever possible, the point of care for estimation of hemoglobin, and Government of India approves only 2 IV iron. One is iron sucrose and ferric carboxymaltose, where I would like to put in the recent evidences and recent recommendations from the Government of India, especially for moderate anemia. Now, I would like to highlight this study which I did as a Safe Motherhood Committee chairperson in 2021. And this article is published in our own journal, Jogi, that is Anemia in Pregnancy Knowledge, Attitude and Practices Survey, which was done among 1,900 OBGYNs of our country. And the data reflects that 88.7% of the OBGYNs screen anemia in the first trimester, which is fair enough. Still, 12 to 13% are not screening in the first trimester. 53.7% OBGYNs perform only CBC, rest are doing only hemoglobin. Majority of the OBGYNs estimate hemoglobin thrice during antenatal period. 50% of the OBGYNs do not consider thalassemia screening in a woman who is not responding to your oral iron and deworming regularly. Majority of them prefer low dose iron. Among almost half of the OBGYNs prefer to change the iron salt when the patient do not respond instead of escalating to injectable irons. Interestingly, 52% of the OBGYNs evaluate serum ferritin levels before starting IV iron. This is again very surprising that most of the OBGYNs, 50% of them are not actually checking for serum ferritin before giving IV iron. And 43.5% perform hemoglobin estimation as early as 2 weeks. So once they give IV iron, they estimate hemoglobin within 2 weeks, and then 40% only evaluate for postpartum anemia. So these are the results of the data of the survey which we did among the OBGYNs, and this actually paved the path of Safe Motherhood Committee activities all across the country during my tenure. Now, we all know that the total iron requirement in pregnancy is around 1,000 to 1,200 milligram, which increases from 0.8 milligram in the first trimester to 7.5 milligram in third trimester. So why I want to highlight here, there is a study which is done at Belgavi, which is a center of research, where they said that in cases of moderate anemia, if you give this dose of 1,000 milligram early in the second trimester, most of the pregnant women performed very well and they did not land up in anemia. So just 1,000 milligram for moderate anemia in the second trimester, improved the maternal and neonatal outcome. And the study was presented recently in Delhi. The results were presented where the global researchers were also present with the Ministry of Health and Family Welfare. Now, these are the cutoffs that every OBGYN should know. Most of the OBGYNs take 10 gram as the normal hemoglobin. The hemoglobin in pregnancy should be at least 11 gram. Mild is 10 to 10.9. Moderate is 7 to 10. Severe is less than 7 and very severe is less than 4. So when you diagnose anemia, when you treat iron deficiency anemia, number one is first is the diagnosis. You diagnose iron deficiency. Then you check for the severity, whether it is mild, moderate, severe. Then you check for the type of anemia, what kind of anemia it is. Then assess the iron stores, assess the heme portion, and assessment of iron absorption. So the assessment of severity of anemia, as a rule, we should do a hemoglobin estimation along with CBC. That's the first step that you should do, and you must do in first antenatal visit. This will assess the severity of anemia. And for the type of anemia, every OBGYN should know how to read RBC indices and peripheral blood smear. So what does CBC includes? This is from our own FOXI Leadership Development Initiative. This is a guideline. This slide is taken from there. CBC includes WBC count, WBC differential, RBC count, hematocrit, hemoglobin, RBC indices, platelet count, blood smear, RDW, which is again very, very important, and ESR. So once you write CBC, you need not to write again the platelet count or RBC indices. So this includes everything. It has to be very clear. Now, besides antenatal profile specific to anemia, we need to do certain tests if needed, like serum ferritin, TIBC, serum iron, urine routine and routine examination, stool examination. Serum creatinine is also very, very important. Sometimes the patient may not respond and creatinine may be mildly elevated. Thyroid disorders, coagulation profile, LFT, hemolysis profile, sonography if needed, and certain cases you need to do a bone marrow examination. Of course, for thalassemia screening, you have to do HPLC. So what is the approach? First is check the hemoglobin and do a complete, I told you what is CBC, and check for peripheral blood smear and RBC indices. Now, these numbers are important. If MCV is less than 80 femtoliter, this is microcytic hypochromic, and we have to concentrate on this because we are talking on iron deficiency anemia. Normocytic normochromic is 80 to 100 femtoliter, and macrocytic is more than 100. So once you see RBC, you check RBC indices, you check MCV. If it is less than 80, you think of 4 important causes. That is, if you remember the word mnemonic tics, you will remember everything. So T stands for thalassemia, I stands for inflammation, C stands for iron deficiency anemia, C stands for chronic inflammation, and S stands for sideroblastic anemia. So tics is a mnemonic which tells you about the differential diagnosis of microcytic hypochromic. And just remember 2 very important, one is iron deficiency anemia and another one is thalassemia. We are not going to concentrate on normocytic normochromic or macrocytic anemia. So what changes happen in your blood parameters? Number 1 is the ferritin storage is a form of iron, and lower ferritin level is the first sign. So I will show you some of the reports how you interpret iron deficiency anemia. So first sign would be lower ferritin level, and followed by reduction in the size of RBC. This is a second step. And then the third step will be the drop in the hemoglobin. So first reflection of iron deficiency anemia would be lower ferritin levels. And as I showed in the study, most of the OBGYNs are not actually doing the ferritin levels even before giving IV iron. So in settings where, detailed biochemical evaluation is not feasible, a low MCV accompanied by raised RDW is red cell distribution. This is very significant and sufficient to diagnose iron deficiency anemia. So RDW normal values are 14 to 15. If it is more than that, you consider it as an iron deficiency anemia. So as soon as you see a CBC, look at MCV. Less than 80, it is microcytic hypochromic. And if RDW is increased, it is iron deficiency anemia. So sensitivity and specificity of RDW in diagnosis of iron deficiency anemia in pregnancy has been reported to as high as 72 to 97 and 82 to 83% respectively. Now, these are the 2 differential diagnoses should be kept in mind in microcytic hypochromic anemia. That is iron deficiency anemia and thalassemia. The important thing is HbA2 will be raised in thalassemia, but the counts will be normal. So RBC count is again very important in thalassemia. You'll find a RBC count unless until that patient is having iron deficiency anemia. And in iron deficiency anemia, the counts will be reduced, and also the MCV will be reduced, but RDW will be raised in iron deficiency anemia. So when you check for all those things, all the tests, there are n number of tests. The most important one is the ferritin, and serum ferritin concentration forms the most accurate diagnostic test in patient without underlying inflammation, because inflammation also causes an increase in the ferritin level. So first step is reduce ferritin. The second one is the changes in the RBCs. The microcytic hypochromic picture appears. And then the last one is the hemoglobin. Now look at this report. This will give you some idea. Like hemoglobin level is 8.8. She is anemic. She is moderately anemic. If you see the RBC count, it is absolutely normal. It is 4.84. But if you see the MCV, it is 63. The cutoff for microcytic hypochromic is 80. So this is a case of microcytic hypochromic anemia. And if you see the RDW, it is raised, that is 18.4. So definitely she has iron deficiency anemia, but since the counts are normal, this is sufficient enough to throw light that she can be a case of thalassemia. The counts are normal, they have not dropped. So this gives us a possibility that this is a case of iron deficiency anemia, and the general blood picture shows a microcytic hypochromic anemia. Now, this is a second patient whose hemoglobin is 11.4. But if you see the RDW, it's borderline raised. But if you see MCV, a borderline, it's an almost normal, but MCH and MCHC is also low. So in this condition, she's not anemic. She has a hemoglobin of 11. She's not anemic. But since the MCH and MCHC is low, I did a ferritin. This was found to be 10.5. So patient who are not anemic may also be iron deficient. So you have to counsel these patients right from the beginning, even if the hemoglobin is normal. Just looking at the blood picture, you can find out whether this patient is having a low iron. Now, this is the second patient, is a second example. Here, if you see, the hemoglobin level is 9.2. And if you see HbA2 level, this is 5.4. So I told you the HbA2 level is raised in this patient. And if you see the hemoglobin, it is 8.8. RBC count is normal, but MCV is 58.6. So definitely it falls under the category of thalassemia as well as low iron because RDW is raised. So just the RDW was raised, I got a ferritin level done. The ferritin level was 14.3. So this is a case of thalassemia minor where she needs iron because the ferritin levels are low and RDW is raised. MCV is also low in this patient. So the Government of India guidelines say that you have to give prophylactic iron to all the pregnant women 180 days antenatally and 180 days in a postpartum period of 60 milligram of elemental iron. It's not 100 milligram along with 500 microgram of folic acid. Routinely deworming these patients are important. Give 400 milligram of albendazole. But however, if it is endemic, you can repeat after 12 weeks. This is a very important chart from the Government of India guidelines. The basic rule is anything less than 5, you need to give blood transfusion and irrespective of the trimester. Now, if she is a case of severe anemia less than 7 gram% and the gestational age is less than 34, you can give IV iron. Remember the cutoff 34. If it is more than 34 weeks, then again you have to give blood transfusion. For mild to moderate anemia, the first thing is always oral. Once you give an oral dose, the therapeutic dose is twice daily. For prophylaxis, you give one, but for therapeutic, you give twice daily. And hemoglobin should be checked after 1 month. If the rise is not more than 1 gram, then you have to switch over after excluding the hemoglobinopathies to IV iron. So for moderate anemia, the best thing would be giving 1 shot of parenteral iron. Now, recent guidance to the use of intravenous iron among pregnant women released this year only, where our president was also part of this formation. So these are actually first, second, third generation IV iron, where we talk about 2 important iron preparations. One is iron sucrose and another one is ferric carboxymaltose. It is very important to understand that in any IV iron, there is an iron core in the center, followed by carbohydrate shell. The stronger is the binding of the carbohydrate shell with the iron, the lesser would be the reaction. So less labile iron will be released in the blood and the reaction will be less. This forms the basis of first generation, second generation, and third generation IV iron. Isomaltoside is a newer IV iron which has been tried and tested in the Belgavi, and the studies are going on in AIMS also for its use in the pregnancy, and this is a better molecule as compared to ferric carboxymaltose. Again, we all should know that like when we give IV iron, we should give the total dose, which is calculated by Ganzoni formula, 2.4 into target hemoglobin minus actual hemoglobin. Here the target hemoglobin is 11, not 14. And now the Government of India guidelines say it is not 1000 milligram for replenishment of this dose, it is 500 milligram. So maximum dose which comes in pregnancy is around 1000 milligram, not more than that. Now, what recent Government of India guidelines say that intravenous iron may be considered for the management of anemia after ascertaining the cause of anemia. For moderate anemia during pregnancy, after first time, this is the best thing that you can do if patient is not ready to come, or oral is not tolerated or non-compliant to oral, or there is no improvement, as I told you, or rise in hemoglobin after 1 month, that is, it is less than 1 gram, then you give IV iron. So for all moderate anemia after 32 weeks of gestation due to iron deficiency anemia, and in severe cases from 13 to 34 weeks, you can give iron, IV iron. So if there are the contraindications, if there is overload of iron, or there is a hypersensitivity or anemia is not caused by iron deficiency, liver disorders, you have to be very, very particular, like in cases of HELLP syndrome, or patient is having some kind of cholestasis or something like that. You have to be very particular when you give IV iron. This is very, very important. FCM brings about a greater and a faster hemoglobin rise in the treatment of anemia as compared to iron sucrose. FCM exhibits higher stability and antigenicity is much lower. FCM usually requires administration time of very less, it's almost 15 minutes, and maximum dose of total replacement dose in the single infusion is higher for MCM, and it is substantial to give this amount of iron in one administration. So Government of India guidelines say that do not administer more than 1000 milligram of FCM per week, and in total dose should not exceed more than 1500 milligram in any pregnancy. So in a pregnant woman, the pregnant woman should be observed for 30 minutes for any adverse events following infusion of FCM. Important thing is, if you have not calculated from the Ganzoni formula and if you have not given the total dose, the oral iron should be stopped 24 hours prior to the infusion, and ferritin should be checked only after 8 weeks, and the hemoglobin level should be checked after 1 month. Do not check before at 2 weeks. Maximum you should do it after 3 to 4 weeks. Now, regarding iron sucrose, still it is in use. It is cheaper iron sucrose. Most of the government facilities are using it. You have to start slow. The only thing is you should know the maximum dose of iron sucrose should not exceed more than 600 milligram in a week. 600 milligram से ज़्यादा एक week में नहीं देना है. 3 doses of 200 milligram each is a dose which iron sucrose should be given. Regarding isomaltoside, this is a new molecule introduced in Europe. It is DCGI approved, and it is also approved by US FDA in January 2020. The only thing is you can give much higher dose of isomaltoside as compared to ferric carboxymaltose. And there are a number of studies which have come up that isomaltoside is a safer drug, also can be used in the pregnancy and reduces the length of the hospital surgery, and maybe in years to come, it will again be endorsed by the Government of India guidelines. This is the fact that we all do not know about it, that FCM causes low phosphate levels. So sometimes if you give FCM, patients do complain of muscle pains and fatigue. This is all because of low phosphate levels. And this was also proved in the Belgavi study where they used FCM and isomaltoside. Hypophosphatemia was more common in FCM as compared to isomaltoside. Definitely the lesser visits are required. The rise in the hemoglobin is much better with the isomaltoside, and the responders with more than 2 gram increase were higher as compared to iron sucrose. So when you give IV iron, you have to keep a watch on pulse, blood pressure, respiratory rate, and all other signs. Mild discomfort during IV infusion, you should not stop it. Watch for some time and then again start. Most of them, stop or discard IV iron. You should not do that. Mild reactions can happen and they settle down. So you have to be very observant and careful when you give IV iron. Again, it is important to know that hemoglobin level in a pregnant woman should be checked 4 weeks after the administration of IV iron. This is all Government of India guidelines. And IFA tablet need not to be given for 3 months post-infusion to pregnant women. So, अगर आप पूरी total dose of IV iron देते हैं, then there is no need to supplement oral iron. This is the fact, and it has been well written in the Government of India guidelines. So after 3 months, you can re-evaluate. If need be, then you can start oral iron. So to summarize, adolescent period, consider correction of iron deficiency anemia. Pre-pregnancy counseling is important. Optimization of hemoglobin up to more than 11 gram. CBC should be routinely done in all the patients. You should not only do hemoglobin. Confirm iron deficiency anemia by microcytosis and RDW and ferritin, which is 3 important tests that you should do. Serum ferritin should always be checked before IV iron. This is very, very important. Rule out hemoglobinopathies. In moderate anemia in the second trimester, just a total dose of iron infusion. You may, this patient might not need oral iron, and availability of IV iron infusion would potentially facilitate improved compliance and better outcome. So just give you 2-3 slides about the idea what we did. We did 2 projects, one in Jharkhand and another one is Karnataka, where we trained the healthcare workers and doctors on anemia, and there were a lot of gaps in these. One paper from Jharkhand is already accepted by FOXI in Journal of Obs and Gynae. It will be soon published. The data was very promising, that there are many challenges in the treatment, diagnosis, and the and the management of iron deficiency anemia. So even Dr. Vidya Thobi is here. She was a president when she took over this project in Karnataka, and we onboarded almost 30-40 facilities where trained doctors as well as healthcare worker, and Dr. Arul Kumar and Dr. Shyam Desai sir, Dr. Hima Devakar, everybody was part of this program, and the results are very promising. We made these charts on iron deficiency anemia, gave them the logbooks, tried to improve the situation there, and it has changed. These facilities are showing remarkable improvement in the management of anemia and GDM. So these are all IC materials which we printed for iron deficiency anemia. And friends, believe me, lot needs to be done for anemia diagnosis and management in our country. So with this, I end my presentation, and this is my humble request that along with Sneha, I am also going for the post of Vice President North Zone Foxy, and I do need your support and cooperation in this endeavor to, achieve my mission of serving more to this organization, as I have already been doing for past so many years. Thank you so much.
We request the chairperson to make few comments, and if at all there are any questions,
Thank you.
Dr. Preeti can answer.
Thank you, Dr. Preeti Kumar.
Thank you so much, Dr. Prabhu. Thank you so much.
This is a wonderful lecture. Before it started, I was thinking that what I'm going to speak in such a old cliche topic of iron deficiency anemia, which even undergraduates do not like.
Yes, sir.
But then you highlighted so many things new. It was just wonderfully done.
Thank you, sir.
And anemia has been a permanent problem. Whatever government does to supply iron tablets to the pregnant women, to supply to the school girls, that problem, if we consider iron deficiency anemia as a disease, is the highest prevalence disease at present amongst all diseases.
Sir, I showed the data of Gujarat. As you can see now, in Gujarat, the 62% of the pregnant women are anemic. So you should do something for the Gujarat, maybe some training programs or whatever. But NFH's data clearly shows there had been an increase of 11% in Gujarat.
Yes. So yes, and this your data has inspired us to do something, and we, along with I'm the president of Surat Society, and with other presidents, I think we should do something about Gujarat.
Yes.
So thank you very much, and I wish you all the best for your
Thank you, sir.
election.
Thank you, sir.
It was really wonderful. I really appreciate.
Thank you, sir.
Prabhu sir, please invite everyone for Surat conference.
Yes.
अरे सूरत आ रहे भाई, हमको रहने का है इंडिया में, सूरत नहीं आके कैसे चलेगा?
Yes, Sarfraz. Dr. Kazi, thank you for reminding. I keep forgetting, and Kazi has been pushing me all the time. I really invite you all very heartily at the Foxy Presidential Conference on 5th, 6th, and 7th of July at Surat. It's in a 5-star hotel, and we have wonderful scientific program. And of course, Surat is known for its food and hospitality and diamonds. So we will. We have a lab-grown diamond stall, and we are going to give 24 carat rose, petal rose to everyone.
Wow!
क्या बात?
Wow!
बढ़िया.
Very nice.
प्रफुल्ल भाई आज
Yes.
प्रीति जी ने जैसे बोला ना, वैसे आपको आयरन ऐड करके ढोकला देना चाहिए कॉन्फ्रेंस.
Oh yeah, but yeah, I think even gynecologists are anemic, so conference में तो वही आएंगे.
88% of the gynecologists, they are anemic. And Preeti ji, एक रिसर्च बीच में था कि D3 deficiency causes anemia, iron deficiency anemia.
हेलो एक्चुअली डॉक्टर अजय, एक्चुअली जब आप ये टेस्ट करते हैं ना फेरेटिन, तो दे आर यूजुअली न्यूट्रिशनली सभी डेफिशिएंट आते हैं इसमें.
But D3 deficiency causes absorption hampering.
मे बी आई एम नॉट श्योर अबाउट इट.
I'll send you the
विटामिन डी का सभी से लिंक किया गया है, डायबिटीज एवरीथिंग, but I'm not sure whether vitamin D causes any, increase in the any increased absorption, affects the absorption of an iron.
I'll send you the.
I don't know. Dr. Suchitra can add, or Dr. Lakshmi can add to it.
Suchitra madam is there.
I haven't heard of vitamin D because vitamin D is nutritionally linked to everything.
Yes, it is nutritionally linked to everything.
All the micronutrients, manganese, zinc, selenium, ये सारे छोटे-छोटे प्रमाण में they cause a deficiency in absorption.
Yes, yes.
Vitamin D का direct correlation नहीं पता चला है, but we will definitely find out. But can I just add one thing, Preeti? It was an excellent talk with all the you were given all the percentages, so people actually know what is the stage. Just wanted to say one thing: in a thalassemic patient, also you can give IV iron, provided the ferritin levels are low.
So-
If in a thalassemic patient, thalassemia minor, I'm talking about. If in a thalassemia minor, the hemoglobin is less and you're tempted to give, don't give it if the ferritin levels are high. If the ferritin levels are low, you are justified in giving FC.
Suchitra ji, I showed one slide where hemoglobin was 8.8, HbA2 was 5.6. Their RDW was rate 18 point something,
Correct.
and ferritin was low. So that is why I told that you can give iron
Yeah,
deficiency.
that's what I said. Just to tell people that
Yes.
right and left OPD में आप दे दो FCM, no problem. But remember that you have to check for thalassemia.
Thalassemia, yes.
Yeah. If you don't want to do the test of HB by HPLC, you can do the Menser's index. You
Now,
can
even they do it, Ms. Suchitra ji, automatic वो दे देते हैं, Menzel instead दे देते हैं. If you want
Nowadays
to
they are
continue.
reporting, giving in the report
Yes,
itself.
they are
but
giving.
even when you look at the MCV itself, if it's low, and if the RDW is high, that also gives you a doubt.
Yes.
But
Right.
so there you can still
And if the patient is in a state of iron deficiency, even though she has thalassemia, we should give, rather we are justified in giving the iron, injectable iron.
Yes, thank you, Dr. Suchitra ji, for highlighting this thing, because many people think that in thalassemia we cannot give iron. But yes, thank you for highlighting this, that you can do ferritin levels and then you can give iron if it is deficient.
Thalassemia minor. Thalassemia
Yes.
major is a completely different thing.
Dr. Praful,
It's a different thing.
I showed one report of that. That is why I showed the
Yes.
report. It was a
Yes,
case
yes,
of
you showed.
thalassemia minor. Yeah.
Yes, ma'am. Suchitra ji will be missing you at Surat. You were coming and then you.
Taken a commitment. If I'd known about your lab grown diamonds, you are giving me, aa jati thi.
अभी कौन सा टाइम है अभी
I
चलिए
tell
अभी
you,
चलिए
extremely affordable diamonds, and nobody can tell it is lab grown. It is just like IVF babies. Nobody can differentiate IVF babies from the normal babies.
So I think Praful sir is giving one more reason to come to Surat. Though we are
Yes.
here to join you, sir.
Yes.
Praful sir, you can keep competition to identify real diamond versus lab grown diamond.
That's a good one, huh? The one who identifies correctly gets a real diamond.
No, nobody can really. Even the jewelers cannot do unless it is sent to a proper laboratory.
Bapre.
Because
such a
exactly, it is just the IVF I'm giving simile, not for no reason. It is exactly the same thing that we do naturally in IVF. So they exactly do what the natural diamonds are growing. They provide the temperature, pressure, everything in the lab. They create the natural atmosphere in the lab. So that is why it's exactly the same.
And what is the price difference?
Oh, unbelievably. Like you can first time give your wife a 3 carat or 4 carat diamond easily, affordable.
Great.
Preeti, once again, excellent talk. And
yeah,
all
very
the
nice talk.
best.
Thank you so much.
Always gives a lot of clarity and a lot of food for thought.
Thank you so much.
Well done and best of luck.
Thank you so much. Thank you.
Thank you, Preeti ma'am. Thank you, Chairperson. I think we should move forward. I would request Dr. Kirtan to introduce the panelist.
Yes. So thank you, Chairpersons Dr. Praful sir and Dr. Sanjay sir for chairing the first session, and thank you so much, Preeti madam, for the wonderful talk as always. And now we move forward to our second session. That is a very interesting and interactive panel discussion on medical disorders of pregnancy. And the panel discussion would be moderated by none other than Dr. Sneha Bhuyer madam herself. And as discussed already, she doesn't require any further introduction or any other thing. And we would like to invite at the same time our expert for the panel, Dr. Vidya Thobi madam. She is the professor and former head of the Department of Gynae at Al Amin Medical College, Vijayapur in Karnataka. And she is the president of KSOGA 2023, State Advisory PC PNDT Board of Karnataka. So many credits and laurels to her credit. She is the chairperson of the Food, Drugs and Medico Surgical Equipment Committee of FOXI, Best Committee of FOXI award by Dr. Mehru Dara Hasotia 2020. And she has to her credit so many publications, the book chapters, contributions, and so many different credits. So we welcome you, Dr. Vidya Thobi madam. And we have so many different panelists from different corners of Gujarat, so many different societies of Gujarat, and they are expert in the respective fields. And it is our credit that they all have agreed to be with us today for the panel discussion. And I would invite Dr. Kazi to introduce them one by one.
Thank you, Kirtan. First of all, I am thankful to all the panelists because they all agreed by just a one call to attend this prestigious webinar. Our first panelist is Dr. Harsha Tandel. She is right now the president of Valsad OBGYN Society and currently working as full-time gynecologist in Kasturba Hospital since last 12 years. And she was the vice president of society for 2 years. Our next panelist is Dr. Dhwani Rolekar. She is right now the secretary of Valsad OBGYN Society. She has done fellowship in USG and minimal access surgery for training in fertility, enhancing endoscopic surgery from EMAS. And she has contributed a chapter in modern approaches in recent procedure of obstetric and gynecology society. Welcome, Dr. Dhwani.
Thank you, sir.
Our next panelist is Dr. Khanjan Maheshwari, a dear friend of mine. He is working in Agman Women's Hospital. Just before few minutes, I called him. So he was in surgery, and he fastly finished his surgery, and now he's joined here. Right now, he is the secretary of Palanpur Society. Our next panelist is Dr. Lata P. Jethwani. She is from Vadodara. She done her PG from Vadodara, but still she is not able to join the program. We are in touch with her to join this program. Our next panelist is my junior come friend, Dr. Bhavesh Nayak, and he's practicing in Palanpur. Our next panelist, Dr. Sweta Patel. She is from Surat, and she was about to tell something while Dr. Praful Doshi was discussing regarding this gold and everything, diamond and gold. So, Dr. Sweta, before starting this panel, we would like to hear some suspense about Suratian diamonds from you. Please unmute yourself after this introduction. Then we will start with you. Our last panelist, Dr. Deepali Sivasne, and she is also from Surat, and she has work experience in teaching experience of 11 years, publications in various international and national journals, and she is interested in high-risk pregnancy, laparoscopic surgery, and apart from this, she is very much interested in dance and music. Welcome all the panelists, and now one panelist left, Dr. Kartikeya Shastri, and he is from Rajkot. 9 years of private practice he has done in Rajkot. Welcoming all the panelists, and now I would like to hear something about diamond from Dr. Sweta first. Then I will give floor to our esteemed moderator. Sweta.
Like before, it was like that natural diamond were so costly that when we see the carats of diamond in others' finger, like when we can wear these carats like 2 carat, 3 carat. Now lab-grown diamond has come. Now everyone can wear this 2 carat, 3 carat ring. So you can gift your wife also and make them happy. So come to Surat for Foxy Presidential Conference and take this lab-grown diamond to your home and present as a natural diamond.
That's the spirit of Suratians.
Thank you.
Now the floor is yours, Dr. Sneha ma'am.
Yes. So I hope you can see my screen. Yeah. So a very good evening to one and all. Once again, I thank all the president secretaries of Vapi, Valsad, Rajkot and Palanpur societies, and I welcome heartily all my esteemed panelists. I'm sure this is going to be, of course, it's a wonderful mixture of seniors and juniors, so I'm looking forward for all the interesting discussions. So friends, all of you have heard about, the preamble about this aspect of the obstetrics and the emergency obstetrics. So basically, as all of you know, that pregnancy per se brings about profound physiological changes in the body, and that puts almost every system at various risk. On top of this, if at all the lady has some medical disorders or comorbidity, then that becomes an additional risk to that woman during pregnancy. So medical disorders like whatever we know, we have been practicing routinely, the anemia, heart disease, hypertensive disorders of pregnancy, hyperglycemia in pregnancy, thyroid dysfunctions, the commonly or frequently encountered medical disorders, and the rare ones like hepatic disorders, various kinds of infections and febrile illnesses also can pose additional risk to the women. So without much ado, Dr. Harsha, we would like to start the discussion from you. We have this, see already Dr. Preeti Kumar has delivered it. Now this is going to be just the revision. But anemia, the prevalence is almost more than 50%, and that is why each and every Foxian, I would say a gynecologist, obstetrician must know every bit of anemia. And so we are here to discuss this case. Third gravida, para 2 with 3 months amenorrhea. She came to you with complaints of weakness, easy fatigability, breathlessness. And when you examine, of course, there is no history of pain or bleeding. When you examine, the vitals are stable, but there is significant pallor. Per abdominally, it is soft and non-tender. Her hemoglobin level is 5 gram per cent. So what is your diagnosis and how do you investigate her? Dr. Harsha.
Good evening, ma'am. Thank you for inviting me for this panel. As Dr. Preeti ma'am has already discussed iron deficiency anemia in so much detail, but looking at this case, first of all, just by knowing the hemoglobin 5 gram, we cannot stamp anything. So we have to first investigate the cause of anemia. So complete.
Why we can't stamp anything? But clinically, we can diagnose.
Yeah, she's severe anemic, but we have to look for the cause of anemia.
Yeah, so early pregnancy with severe anemia. That much.
She's a case of severe anemia.
Yes,
but we have to go for further investigations.
Yes.
So that we can decide the exact management for this severe anemia, ma'am.
Correct.
So we will need some complete CBC. And as ma'am has said, serum ferritin levels, total iron binding capacity, and all that investigations must be needed. And first of all, we have to rule out whether she has any other pathologies like thalassemia or sickle cell disease. So sickle cell disease is very much prevalent in our area. So we may think of that first also.
Okay.
So we have to rule out that. And if she is having any other blood dyskaryosis like sickle cell or thalassemia, we have to rule out whether she is basically.
Right.
So,
Dr. Dhwani, yes. So, Dr. Dhwani, Dr. Harsha has very well enlisted the investigations. Can you tell us what information do you get on complete blood count?
Thank you so much, ma'am, for making me a part of this panel. So a CBC first, three important things which we should see in a CBC is hemoglobin, WBC count, and the platelet count. Apart from this, we also have the blood indices in CBC, which will help us find out which kind of anemia the patient is having, and which will also help us in further investigation and management of the patient. And of course, the WBC and platelet count will help us rule out any infection or thrombocytopenia and other such blood-related complications if the patient.
Correct. So, in addition to the hemoglobin and the various cell indices, it also tells you about the hematocrit and also tells you about the the cell distribution width, RDW, right? Whenever you have this abnormalities in the cell differential count, where you have the peripheral smear. Peripheral smear is also one very informative, very simple investigation, but very informative. It tells you about the exact type of anemia as well, right? It gives you an idea about the reticulocyte count as well. So in addition to this, if at all you have iron deficiency anemia, on the peripheral smear picture, you can go for the serum iron profile, right? So all these investigations, they will help you coming to the diagnosis of severity as well as the etiology of the. Now, how do you manage this patient, Dr. Khanjan? Can we have it from you? Dr. Khanjan Maheshwari? Do we have Dr. Khanjan? Anybody else can take up this? Dr. Thani, you can continue this if at all he is not
Hello.
here. Hello.
I'm Dr. Khanjan Maheshwari.
Yes, yes, please go ahead.
Because she is severe anemic and 3-month amenorrhea. We have plenty of, and there is no emergency right now. And after differential diagnosis, if she is most likely iron deficiency anemia, and if she is iron deficiency anemia, we can prescribe iron after 12 weeks of pregnancy.
Okay, okay. Any
And green leafy diet should be prescribed to her.
Okay. Anybody differs from this opinion? She's got hemoglobin of
Yes.
5 gram
Yes.
percent and she's symptomatic.
Yes, sir.
Okay.
Yes, sir, madam. I am
Yes,
Dr.
there is
Bhavesh
Bhavesh.
Nayak.
Yes, please go ahead.
Hello. I am Dr. Bhavesh Nayak.
Yes.
If it is at the late 3-month amenorrhea, she is likely maybe chronic anemia, or if it is symptomatic for anemia, so like breathlessness or dyspnea or difficulty in doing routine work, immediately we need to increase the oxygen carrying capacity. In our unit, we prefer the 100 ml RBC gradually alternate day to compensate it, increase the oxygen carrying capacity of mother. And after that, we should search for cause of anemia, type of anemia. And generally the anemia, this type of anemia is generally mixed anemia.
Yes,
It may
Dr.
be
Bhavesh,
iron,
to partially we agree to you, but if you remember, Dr. Preeti has also said that it is, as per the Anemia Mukt Bharat, 5 gram percent hemoglobin level, irrespective of the period of gestation age, you have to go ahead for blood transfusion, right?
blood transfusion immediately to increase the oxygen carrying capacity.
Right, right. And then, of course, you decide what is the etiology, to investigate, and then you go for whether she requires supplementation, iron supplementation, and what else. But irrespective of the period of gestation, hemoglobin of 5 gram percent, warrants blood transfusion. Okay?
Yes.
So that you have to also
agree,
make a consensus on this. Okay. So
we can do blood transfusion and settle the patient, and once the patient is stable, like then we can switch over to parenteral iron administration and the dietary precaution and everything we can advise our patient. But first we need to do blood transfusion and stable the patient.
Correct. So
and here we have to keep in mind that there will be chances of volume overload, so we have to take all this precaution while we are doing blood transfusion.
In our unit, madam, pediatric blood should be transmitted. 100 ml, that is 100 ml bottle. And pediatric RBC was transmitted on alternate day. Generally, the increased oxygen carry capacity increase after 48 hours after the blood transfusion. So we can avoid the overload. So you can transfuse the pediatric bottle.
Yes. So first and foremost, basically, it should be a packed RBC and not a whole blood. Okay. The transfusion has to be given very cautiously in small volumes, and of course you have to give it very slowly over the calculated period. Of course, you have to see that the patient is not landing up into volume overload, and if at all required, you can go ahead with giving the diuretics. Okay, so all these precautions you have to take, but very precisely. 5 gram percent anytime during pregnancy requires blood transfusion immediately. And then, of course, once you stabilize, you evaluate the patient, and then you manage this anemia as per the specific etiology. Correct. Now, suppose your patient has got iron deficiency anemia. She's now only early pregnancy. Can we give her injectable iron? What kind of iron, and how do you calculate?
Ma'am, oral iron as such cannot be given during first trimester of pregnancy because of associated nausea and vomiting. But parenteral iron can be given with due precautions. And for that, we have to calculate the dose of iron sucrose, which can be calculated.
Are we using iron sucrose nowadays?
No, sorry, parenteral iron. Most commonly used or most effective is the ferric carboxymaltose.
Correct.
And the dose will be calculated according to the formula, which can be calculated as 2.5 into hemoglobin deficit, which is the standard here target hemoglobin minus actual hemoglobin of the patient into the body weight of the patient in kilogram plus extra for the storage of the patient.
1000 milligram extra for the stores to replenish the stores. right?
Yes.
And then, of course, you go for supplementation.
Yeah,
Yeah.
can I interrupt in between?
Mm-hmm.
Sorry.
Please.
Actually, just go to the previous slide. I clearly showed now recent recommendations are adding 500 milligram. It's
Mhm.
not 1000 milligram.
Mhm.
And the target hemoglobin is 11, as she rightly said, but here it is 500 milligram. So now government endorses 500 milligram for Ganzoni formula for calculation of total dose of iron. So iron sucrose is definitely being used in many centers.
Yes, even at the government
Yeah,
hospitals,
many
even
are using,
today,
yes.
if the 5 doses of iron sucrose, that is a routine even today at
Yes.
PHCs and sub-district
UP,
hospitals.
we are many public facilities like
Yes.
CSCs are using,
Yes.
but I don't know about Maharashtra and about
They are
Gujarat.
using. They are using still. Only in private hospitals, we are preferring the
FCM, yes, FCM.
Credit card.
Okay. So, Dr. Bhavesh, we come back to you for the discussion. Do you think that, such a severe anemia has developed all of a sudden, or, that all of you know the answers, you have to just say it out precisely. Whether she develops this anemia so severely all of a sudden, or the anemia develops over a period of time?
In first trimester it is likely to be chronic anemia, but we should also rule out the other source of bleeding such as a bleeding per rectum or any
No, that is not the
history of-
question. That is not a
Oh.
question. Dr. Bhavesh,
Well,
I am asking you
is-
whether all of a sudden she develops severe anemia or she goes through various stages of anemia.
various stages, it is a chronic anemia, and during the progressing of the pregnancy, anemia is increased if it is not corrected.
Yeah, but here our patient is in first trimester only.
It's likely to be chronic anemia.
Okay, so can we have some other panelists coming in? What are the stages of anemia, and then how do you replenish? Yes. Yes, Dr. Karthikeyan, please go ahead. Please unmute yourself. Unmute.
કાજીએ ભરાઈ દીધો એ પેલા એમાં
decrease in
એના
serum ferritin level. The
પ્રશ્ન
decrease in
પૂછે
ferritin level
Hello.
will be followed by hello. Am I audible, madam?
15 મિનિટ લાગશે પતવા.
Hello.
Yeah, please
Ah,
go
madam.
ahead. Dr. Karthikeyan.
Yes, madam. In the first stage,
Dr.
there will be
Karthikeyan, yeah, you can go ahead.
ma'am, in stage 1 there will be a decrease in ferritin levels.
Mm-hmm.
The decrease in ferritin levels will be followed by decrease in the RBC count. Red blood cell count on CBC, there will be decrease in RBC count, which
Right.
will be followed by decrease in hemoglobin levels.
Yes, yes. So the first stage is only depletion of the iron stores, which will be evident only on the serum ferritin levels. And the second stage is, what you are talking about, the serum iron levels. The various indices also come down. And thirdly, actually the hemoglobin level comes down. That is a third stage. Okay. So it's not over the period of, it's not as a emergency it's developing unless it is a acute loss, right? Can I ask all of you to mute, please? Only the panelist who is speaking. Yeah. So, yeah, so, okay, so first stage is, depletion of the iron stores, and then, of course, you have the serum iron levels going down, percentage saturation going down, and then, of course, you have the, fall in the hemoglobin levels. So what is the effect of anemia on pregnancy and pregnancy on anemia? Hello?
Hello.
Yes, please continue. It was for Dr. Khanjan, but if Dr. Karthikeyan Shastri is taking up, we can continue the discussion.
Like we can
Yeah. Yes, Dr. Sweta, go ahead.
we can divide the effect of anemia on pregnancy like on baby or on mother. And in mother, like during antepartum phase, during labor phase, in postpartum phase. On baby, we can say there is when there is depletion of iron store in mother, then obviously there will be depletion of iron store in baby also. There are likely that baby will have low birth weight or intrauterine growth retardation and such complications. During pregnancy in mother, there are chances that they may develop preeclampsia, recurrent infection, chances of preterm labor, or sometime in case of severe anemia, there will be chances of heart failure.
to heart.
During labor, again, there is chances of postpartum hemorrhage and infection and all that thing. During postpartum phase, there is chances of puerperal sepsis and rarely cardiac failure or pulmonary embolism in case of severe anemia. So these are the effects of anemia on mother and baby. Like itself, pregnancy has effect on anemia. Like during, we all know, during pregnancy there is a expansion of plasma volume, so there will be hemodilution. So whatever the mother who is already in iron depletion stage or somewhat anemic, there will be increase in hemoglobin dilution level, and there will be
aggravation of the anemia. Pre-existing will be aggravated, right?
Yes, yes.
Okay, so the anemia definitely has hazardous effects on the pregnancy, right from early pregnancy, the possibility of spontaneous abortions, preterm labor, preterm PROM, intrauterine growth restriction or demise, even fetal death, and of course, abruptio placentae and antepartum hemorrhage. During labor, you have, what is called as labor dysfunction. You can have labor abnormalities, prolonged obstructed labor also can be there, and then operative intervention, fetal distress. During puerperium, you have, immediately after delivery, you can have PPH, adding to the severity of the anemia, puerperal sepsis, even lactation failure, and then of course these postpartum depression and psychological problems will worsen. And then fetal outcome, as you have already said, low birth weight babies, prematurity, infections, and of course the fetus, baby in future being chronically anemic. So these are all the effects, So as we have already talked about the various phases, I would just ask you only, Dr. Sweta, rather than having such severe anemia during pregnancy, should we screen them before planning the pregnancy? If at all, how we should do that?
Yes, ma'am. It is always better than prevention is always better than cure. So here comes the role of preconception counseling and preconception visit to the gynecologist. Like in conception part, we can counsel our patient. We take detailed history, like they have any history of menorrhagia, weakness, fatigue, or blood in stool. They have habit of pica. Or we can do general examination for pallor and all these things. And in blood investigation, we can advise our patient to go for complete blood count along with peripheral smear, so we can diagnose the completely anemia. And HB electrophoresis is like in my practice, I do HB electrophoresis of all antenatal patients, so we can come to know about the thalassemia, sickle cell anemia, other HB hemoglobinopathies.
Yeah, I will interrupt you here. Is HPLC recommended as a universal screening during antenatal period? Is it recommended as a universal screening?
And we can add also thyroid stimulate TSH testing also in TSH.
No, my question to you is hemoglobin electrophoresis or screening for hemoglobinopathies a mandate? Is it mandatory to screen?
Yes, ma'am. It is mandatory. If there is any like thalassemia minor thing, we can explain our patient that.
Yeah, our question is different. See, it is not mandatory as far as the Government of India recommendation is concerned, though it is advisable to go for routine screening. Okay. So for the safety of the patient and for safety of yourself, it is good that we should screen for even hemoglobinopathies, but it is not considered as mandatory as far as the routine antenatal care is concerned. Okay. So when do you want to screen these pregnant women? What is the recommendation by Government of India? So Government of India recommends that all these pregnant women should be screened at the very first point of antenatal contact, that is the first antenatal visit, because the incidence of anemia, as I said, it is very high, more than 50%. And of course, there are definite guidelines by Government of India and Ministry of Health and Family Welfare. Of course, FOXI also has a GCPR about this. So the recommendation is that at first visit, then between 16 to 20 weeks, 24 to 28 weeks, and in the last trimester, 34 to 36 weeks. In fact, medico-legally, it has been said that it should be the investigations or at least CBC should be done at least 24 hours prior to any intervention or labor. Okay, so ideally we should do it pre-conceptionally, as you have said it, right? And then of course the pre-conception screening and counseling. And for certain communities where the hemoglobinopathies are very common, we should in fact do it for premarital, right? Because
Yes,
one
yes.
partner is having the trait and other partner is also having trait, then that means both are carriers, the offspring can be a sufferer, and that is why we should go for screening premaritally. Okay, so now we come to the second case now, and we go to Dr. Dipti Sivasane. Do we have her, Dr. Dipti?
Yes, ma'am. Good evening. It is
Good
Dipti
evening.
Dipali
Good evening. I
Srivastava.
request you to please rename yourself. Thank you.
Yeah.
So, Dr. Dipti, we have this unregistered primary gravida, married for 2 years. She comes to you with 9 months amenorrhea, and she has pain in abdomen, mild vaginal discharge, fever, cough, and breathlessness. When you examine, you find that she's got tachycardia, and of course, there is no pedal edema. She has mild pains, but suddenly she develops a rupture of membranes. So you try to augment her. Patient doesn't progress. In fact, she lands up into fetal distress. So you have to take her up for cesarean section. When the anesthetist examined her, he found that there is a diastolic murmur. Okay. So now the patient was given regional anesthesia and she's taken up for cesarean section. Baby was delivered. Suddenly she became severely breathless. So what is your diagnosis and how do you classify this case? Of course, how do you manage this patient?
Ma'am, as per history, patient is having on examination, like first on history, she was having pain and fever, and then she landed up in ruptured membranes, and the augmentation was done. And when she was taken for LSCS, anesthetist examined, it was diastolic murmur. So definitely there is cardiac pathology.
Yes. Why do you say so? Why do you say so? During pregnancy,
because
you always get
during
some kind of
pregnancy,
murmur.
during pregnancy, physiological murmurs are also heard, but diastolic murmurs are seen
So
in
those
cardiac.
physiological murmurs are usually they are systolic.
Systolic, but diastolic murmur suggests the cardiac lesion or cardiac pathology.
Yes.
So she is having cardiac pathology. Now she was taken for LSCS, and she suddenly started develop breathlessness after the baby delivery, which indicates that after baby delivery there is auto transfusion. So maternal blood is placental blood is again circulated into the maternal circulation, which leads to pulmonary congestion or increased venous return to the lungs, which results in pulmonary congestion in rheumatic heart disease. So
What
this
is
is
your
the case of
diagnosis?
rheumatic heart disease. And most probably, since it is a diastolic murmur and she developed pulmonary edema, so it should be mitral stenosis, which is the commonest cardiac pathology during pregnancy.
Right.
And apart from that, the previous
What is the
question.
NYHA grade you feel?
Ma'am, she was she. There is not mentioned, but since she was unregistered patient, that means she was not having any symptoms.
Yeah, there is a mention that she was breathless even when she was hospitalized. Okay.
Yes.
Fever, cough, and breathlessness.
But prior to that, she must be asymptomatic. That indicates it must be NYHA class 1 or 2 grade.
We have never said that she was asymptomatic. We don't know whether it is because of fever and cough. We are saying all the time that she was feeling breathless, right?
Yes.
But maybe mild breathlessness, which worsened on after the delivery.
After the delivery.
Right. So this is definitely NYHA grade 3 or 4. Correct?
4.
Okay. So now that you have already said that she's having this diagnosis of rheumatic heart disease, almost sure that it is a mitral stenosis and NYHA grade 2 or 3. Okay. Though not 3 or 4, but NYHA grade 3 definitely.
2 or 3.
And she had all these aggravating factors of infection, labor pains. I think somebody is not muted and talking. Yeah. So we have, so what precautions we should have taken, like what precautions we should have taken to avoid this catastrophe? That is what we will discuss first. What do you think is the, as you have said, it's a acquired heart disease, a rheumatic heart disease. What are the other etiologies of heart disease and how do you categorize them?
Sorry, ma'am?
What are the other, how do you categorize heart diseases? What all types of heart diseases you meet during pregnancy?
they can be congenital heart diseases and acquired heart diseases.
Right.
Acquired heart diseases can be, most common is the rheumatic heart disease,
Right.
Followed by cardiomyopathies. And
Nowadays it is becoming quite common, peripartum
cardiomyopathy. And congenital heart diseases can be there in form of
you can have cyanotic and
cyanotic and acyanotic heart disease.
Okay.
So most cyanotic heart diseases can be because of the shunts, left to right shunts like ASD, atrial septal defect, VSD, ventricular septal defect. Whereas cyanotic heart diseases can be seen in form of left to right shunts.
Correct. So, in fact, Pallostetrology and Eisenmenger. Okay.
Eisenmenger syndrome.
So your patient was actually almost in the, the symptomatic at rest. So she was almost grade 4, but if not, we can take it as grade 3, right?
Grade 3.
So this patient was what? Whether when you try this risk, according to risk, when you try to categorize this patient, your patient was fitting into which group? Low risk, medium risk, or high risk?
It should be medium risk, ma'am.
Right. Yes. So your patient is fitting into medium risk, because she has had labor pains, rupture of membranes, infections.
Cardiac overload has landed her up in the complication.
And because she was subjected to cesarean section, so the preload was also given, right?
Yes.
She gave fast IV fluids, and then maybe the anesthetist has given methadone. We are not sure, that is not mentioned. So all these factors have added to the third stage load on the heart, and that has led to sudden cardiac failure. Okay. So what are the poor prognostic indicators? Dr. Karthikeya, can we ask you? Can we have it?
Yes, ma'am. Dealing with mitral stenosis, the most common heart disease with pregnancy. Whenever the NYHA classification grading is more than 2, which is always indicates a poor prognostic factor. Dealing with mitral stenosis, particularly on echocardiography, when the mitral valve diameter is less than 1.5 centimeters, when it indicates for poor prognosis due to the high reflux and more chances of pulmonary congestion.
Yeah, we label it as critical mitral stenosis.
Yes, ma'am. Any event during pregnancy, any cardiac event noted, prior cardiac event noted before before the delivery, which will also undercome as a poor prognostic factor.
Right.
Any signs of heart failure, tachycardia, arrhythmia, or past history of ischemic attacks will end up this lady into a poor prognostic categorization.
Right. And whenever the ejection fraction is less than 40%, then of course the two conditions where, primary pulmonary hypertension and Eisenmenger syndrome, these are the poor prognostic indicators. In fact, we advise them not to become pregnant, right? So what are the aggravating factors you feel, Dr. Harsha, in this case?
Ma'am, she must... Good. Hello?
Yes, please go ahead. We can hear you.
Yeah. Ma'am, she was having fever, and maybe because of that, she developed some early sepsis. And she was unregistered, so maybe she was having some prolonged labor somewhere. So all that can lead to more of a, load on the heart. And she was not diagnosed before. So maybe that is one of the reasons that we were not aware of that. So maybe she was loaded with IV fluids for her to augment her labor. And all that can lead to the aggravating of the heart failure during LSCS.
Yes. So the message here we have to give is, put a stethoscope on every woman, every pregnant woman, or I would say every woman, whosoever comes to you for any of her problems, and auscultate. Make a point to auscultate. If at all you can find any abnormalities, get it evaluated from the physician or cardiologist. Maybe she needs further investigations, but we have to either rule out or confirm the pathology, whatever she has. Then, of course, you have anemia, infections, hypertension, the labor pains, and of course, any sort of pain which can precipitate, and of course, multiple gestation or caffeine, alcohol. These are the aggravating factors. Okay. So, Dr. Dhwani, can we hear from you? How does pregnancy affect the heart disease?
Ma'am, any kind of heart disease ensures that the heart of that person is weak, and pregnancy is a situation in which there are multiple cardiovascular changes in the body, and one of the major changes is the increase in the blood volume. So any kind of heart disease is going to worsen with pregnancy. And also there is changes in immunity. There are changes in the protein balance which can cause endocarditis, pulmonary edema, and other cases like pulmonary embolism, rupture of aneurysm. And basically the heart is subjected to a lot of acute stress in pregnancy.
Right. So you have to take care of all these factors, and of course, what is the effect of pregnancy? We all have already discussed this. So just to summarize that we have to, we have to have a multidisciplinary approach for this patient. So first and foremost, you have to auscultate, confirm or rule out the heart disease. If at all she has heart disease, you have to avoid the aggravating factors. You have to take care of, all the precautions, whatever are discussed, we have discussed till now. And then of course, you have to manage such patients. The tertiary care center, or where you have a multidisciplinary team, which actually has obstetrician, cardiologist, anesthetist, neonatologist, and a cardiovascular thoracic surgeon, and of course, a specially trained nursing staff as well for the monitoring. Okay. So we go ahead with the next case now. Do we have Dr. Bhavesh Nayak here? Dr. Bhavesh?
Yes, madam.
Yes. So we want to hear from you about this case. This is a 22-year-old primary gravida coming to you for the first antenatal checkup at 10 weeks. Her BMI is 30 kg per square meter. That is, height is 152 and weight is 69. She doesn't have any family history of diabetes. Okay. So does she need to be screened for diabetes? If so, yes, then when and what screening test you'll be using?
Madam, as at the 10 weeks, her BMI is 30 is more. So already she is in high risk. So we should go for HbA1c. We should rule out either it is maybe pre-conceptional diabetic or not.
Yeah. See, my question to you is, you are right in a way, but what our question is, does she need to be screened for diabetes? So what is the screening test? What is the screening test?
Routine initially first the routine random blood sugar. Routinely.
Anybody else wants to differ? What is the
glucose tolerance test? 75 gram glucose tolerance test.
GTT is generally, madam, but it is in, after if it is gestational diabetes, generally it is done at after 20 weeks of pregnancy.
No,
24 weeks. 24 weeks.
That is
24 weeks. GTT is advised at 24 weeks.
No.
But
So
she's
no. Just Dr. Bhavesh, let me clarify you that previously, that is almost 2 to 3 decades ago, when we used to have a patient with family history, age above 35, obesity, and the patient who is having PCOS, these were the women we used to screen. That is only high risk screening. Okay. But nowadays, the dictum is universal screening for hyperglycemia in pregnancy. Okay. So that every woman during every pregnancy should be screened for diabetes. And the screening test has to be uniform. It is single step 75 gram oral glucose tolerance test or oral glucose challenge test. Okay, now somebody describe, and this should be practiced routinely. All of us are practicing since last 10 years. We are doing this test for every pregnant woman. Okay.
In first trimester, madam.
At the first visit, I'm going to ask you when. So first test should be done at the first antenatal visit, and so second should be between 24 to 28 weeks.
Yes, you should done the second at 24 weeks again.
Yes, but then not that routine what you are saying, oral glucose tolerance. It is 75 gram single step OGTT. Okay.
75 gram and single test, and after 2 hours we can see the threshold of sugar. Okay, but in the first trimester GTT may be negative, but it's in the GDM it after 24 hours 24 weeks it may be positive.
Yes.
So we can only rule out the preconceptional diabetes or not in first trimester, and GTT should be repeated at 24 weeks. Must be repeated 24
both the
hours.
times you are trying to rule out gestational diabetes. Okay?
Okay,
Both the
okay.
times. You're
Agree,
trying to
agree.
rule out, in fact, I would say you're trying to rule out hyperglycemia in pregnancy, and
Yeah.
then you're trying to come to the final diagnosis whether she has pre-existing overt diabetes or she has only gestational diabetes. Right.
Yes,
So now, Dr.
agree.
Bhavesh, let me get it from you. Why are we worried so much for hyperglycemia in pregnancy? In other words, what are the effects of hyperglycemia or diabetes on the fetus and on the mother?
If it is pre-existing or pre-conceptional or in first trimester, it may be associated with
We're
miscarriage.
talking about hyperglycemia in general.
Hyperglycemia, it is associated with miscarriage or fetal anomaly during the organogenesis period. If it is mother become hyperglycemic, likely to be fetal anomaly, most commonly the cardiac or neural tube defect, or maybe go to miscarriage. So we should be aware of the hyperglycemic status of the mother during first trimester.
Fetus you were talking about.
In second or late trimester, we should worry about the fetal growth restriction, placental calcification,
Not macrosomia.
macrosomia.
That
We
is the
should
most
be alert for
characteristic.
macrosomia. We should be aware of the macrosomia, and if the estimated fetal weight, the threshold value is 4.5 kg, more than 4.5 kg, we directly go for the cesarean section. And most likely during the labor, it most likely go for the shoulder dystocia if it is uncontrolled diabetic.
Okay, so we have not discussed what are the effects of this hypoglycemia on the mother.
Mother, if it is pre-existing, it is more likely to we can routinely go for the fundal examination and renal function. If it is pre-existing diabetic, then in pregnancy it is likely to go for the retinopathy or nephropathy, and it maybe go for the decay ketoacidosis, because in the pregnancy the lower glucose level may go for ketoacidosis than the normal person.
Yes.
In the normal decay, in the pregnancy, the lower glucose value
Can we have the
may
video on, please, Dr.
easily go
Bhavesh?
into decay. So decay is diagnosis during pregnancy is very difficult. So we should be alert for that also.
Okay. Anybody wants to add anything? I can see.
Ma'am, in maternal complications, studies have shown that gestational diabetes mellitus are associated more commonly with preeclampsia. So chances of preeclampsia are seen in 20 to 30% of gestational diabetic patients.
Right.
Secondly, there are chances of recurrent infections in cases of hyperglycemia during pregnancy. Thirdly, there is a more chance of macrosomic fetus during gestational diabetes mellitus. So chances of instrumental delivery, chances of traumatic PPH are higher in gestational diabetic patients.
Correct. And
also on long-standing cases, patient may develop diabetes mellitus in her later life also. 30 to 40 patients have been found to suffer from diabetes in later life.
Okay, so you have talked about fetus and mother. So these are the findings. These are the effects of diabetes on the neonate. You can have neonatal hypoglycemia, hypothermia, polycythemia, and then of course prolonged neonatal jaundice. You can have neonatal respiratory distress syndrome, which is so common, RDS, hyaline membrane disease, and of course, as you said, trauma because of shoulder dystocia. Okay, and long-term obesity or the metabolic syndrome. Okay, and so FIGO, FOXY, NHM, and of course DIPSY, who has come up with this test, universally recommends that there should be universal screening for each and every woman during every pregnancy. Not that first pregnancy में उसको diabetes नहीं था तो अभी नहीं करना है, ऐसा नहीं है. Every pregnancy, okay. So should we use hemoglobin HbA1c for screening?
Ma'am, during a pregnancy, we recommend oral glucose tolerance test as a screening test. But when we have altered values, then we go for HbA1c testing to see the control in last 3 months. Like what is HbA1c? HbA1c is a combination of hemoglobin and glucose by non-enzymatic reaction, and it reflects the blood glucose concentration.
Can we ask Dr. Bhavesh to mute? I think we are getting the disturbance. Yeah. Okay. So, yes, Shweta, please go ahead.
So when
for
suppose we
screening, yeah, for screening we have to use 75 gram single step OGTT. But as you are rightly saying, it is for the prognosis, the control for the last 3 months. Correct. So go ahead, please.
So it correlate with the blood concentration level. Suppose we have done it in first trimester, like in 4 at 6 week or 8 week, it will reflect the preconception level or it last 3 months control. And we all know that there is a higher chance of congenital anomalies. What we are worried about diabetes mellitus or hyperglycemia in pregnancy is diabetic embryopathy. Like there is increased chance of congenital malformation if HbA1c level is more than 8 or 8.5. Like 20 to 25% chances will be there that babies will have congenital malformation.
Yes.
So if we control the HbA1c level near by 6.5, so there will be around 2% or less than it chances of getting congenital malformation.
Correct.
So
you have answered this question. Now only the last question, Dipali, Dr. Dipali. How do you correlate the blood sugar levels with perinatal mortality?
Ma'am, blood sugar level directly associated with the fetal malformations. Like hyperglycemia itself is a teratogenic factor. So during periconceptional period, if there is hyperglycemia, there are very much high chances that fetus is going to have anomalies in central nervous system, cardiovascular and renal system. So there is, it is associated with perinatal mortality, yes. Second thing, again, if there is hyperglycemia, there is hyperglycemia in fetus also. That will result in the increased excessive insulin secretion and macrosomic fetus. So macrosomia itself will again add the complication rate during the labor. So in both ways, high blood sugar levels are associated with the perinatal mortality.
Yes. But these are the actually the levels which correlate. You know, if you have the blood sugar levels of more than 200, the perinatal mortality is to the tune of 35%. If you have blood sugar levels between 150 to 200, you have the perinatal mortality of 16%. And so you have to maintain the blood sugar levels less than 120, I would say around 100, so that the perinatal mortality is almost 4%. Okay. So these figures, you know, all these figures tells you very clearly that there is a stark necessity of strict blood sugar control. We have to not only advise them medication, but we have to give them practical nutrition counseling and guidance along with the medications. Okay. So we have to make sure that it has to be a tight glycemic control during pregnancy. They should be told about the target levels that, you know, before lunch, it should be only between 69 to 90. Lunch and dinner, it should be 60 to 100. And post meal at no point of time more than 120. Right? Okay, so this is how the recommendation is. Now, can somebody talk about the method of, you know, single step? How do you do? I'm sure all of you are supposed to practice this screening. So how do you do this in your practice?
Ma'am, in our hospital, patient is advised to come during morning, but there is no restriction on her dietary intake. Whatever routine diet she's taking, she can come with it. And then we are giving her loading dose
so in
of
fact, you say that it is there is no need to be NBM.
Fasting or something.
Yes, the irrespective of the timing of her last meal. Also, you can go ahead and give the test at the same sitting. You need not call her fasting again on some other day, correct? And then how do you do the test?
Then we are giving loading dose of 75 gram glucose. And after 2 hours, we are measuring the blood sugar levels. Which should not be more than 140, around 140 milligram %.
Correct. So, Dr. Dipali, suppose now the patient is coming to you during first trimester for the first visit. You are giving her this, you know, you are dissolving that 75 gram in 200 or 300 ml of water. You are asking her to consume over 5 minutes, right? Noting down the time, and then you ask her to, you know, collect the blood sample at 2 hours. Suppose she vomits. Maybe it's around, say around after 1 hour. Then what will you do?
Ma'am, repeat sugar should not be given to the patient as it will alter
No. I'm asking you about the interpretation. So I will tell you that if she vomits within first half an hour, you have to abandon the test and call her some other time. But if she vomits after half an hour, then you can continue with the test. Okay?
Yes.
Because majority of the sugar is already absorbed and you will get the appropriate reading. So
Yes.
when you do the OGCT at first visit, then if you find that the blood sugar levels at 2 hours is more than 140, then you label her as GDM and then you manage her accordingly. How? We'll see it later. Suppose this patient is having less than 120, that is normal, but between 120 to 139, then what will you do? More than 140 GDM,
Two-step,
120.
we can go for the second screening test, that is
Yes.
oral glucose challenge test.
Yes,
with
but then
the
do you advise her anything for the diet control? You should advise her, because now here what is called as gestational glycemic intolerance or gestational glucose intolerance, right? So if she starts controlling her sugar intake or carbohydrate intake right from this point of time, what we call it as actually the medical nutrition therapy, then this will avoid her developing into GDM actually. Okay. Now, once this patient is diagnosed as GDM, then how do you proceed? What advice do you give it to her? I think you are only taking that, Dr. Deepali. Yes.
Ma'am, can you repeat the question, please? I couldn't get it.
This slide which you are saying, that is not the question. I'm just asking, suppose she is diagnosed as GDM.
Yes.
Then how do you go ahead? When do you take the next? Yes.
First of all, we have to give dietary management and like strict diet control, and we will assess her for the
So
fasting.
we talk about that only in detail. So what is that strict diet control? How much? She will ask you, madam, strict diet control means what? Why? What should I do? Then how do you tell your patient? Kitna khana hai? Calories kitna? Carbohydrates kitna? Yes, Dr. Karthikeya, I can see you.
We advise them to take 3 major meals and 2 minor meals, considering their diet should cover 50% by carbohydrates, 25% by proteins, and less than 30% by fat. So that's how we manage her. As per her body weight, we allow her 30 to 35 kilocalories per kg per day, and we'll divide in her meals.
Yes, but Dr. Karthikeya, do you not calculate her calorie requirement? Because and then if at all you calculate, then how do you calculate? What are the parameters? सबको सेम तो नहीं एडवाइस करेंगे कि आप 2000 कैलोरीज लो कि आप 2500 लो, करेक्ट?
Yes.
So you have the what is called as gestational weight and weight gain during first trimester, right? So basically BMI is one parameter, and second is of course the level of activity. Okay, so if she is obese already, see, I will show you. This is, if she is normal weight person, then you will advise her to gain 11 to 16 kg. And of course, if she is underweight, you will allow her to gain maybe 12 to 15 kg. If she is obese, you will restrict her weight gain. That is the basic principle. So what are these two parameters? The weight per se, or weight, rather than weight, I would say BMI, and the level of activity. Okay. If she is underweight, and you have to allow her 500 kilocalories. If she is overweight, you have to reduce her 500 kilocalories. Correct? And if she is having sedentary work, then you will allow her only 1900 plus 350. If she is having heavy work, then you will allow her to 2850 plus 350. Do you get it?
Yes.
So weight and level of activity, these are the two parameters to be taken into consider. Okay. Any doubt here?
No, madam.
Yes, Dr. Shweta, do you agree with this?
Yes, I totally agree with it. With strict diet control and restriction of weight gain, and that we can manage by BMI and her daily activities.
Correct. So now your patient is diagnosed as GDM. So you will give her 2 weeks of MNT, what is called as medical nutrition therapy. That means whatever diet, उसको हमने calories कितना लेना है total. So first you calculate the calories and then you advise her the spread. Dr. Karthikeya has said 50% carbohydrate, but if at all she is obese and the sugars are more, we will restrict her carbohydrates to 40%. And then we will advise her the spread. Okay. and individual practical advice we have to give. Correct? So what advice do you want to give? Suppose you have a patient who is non-vegetarian. It is easy for you. You will say you consume maximum, maybe eggs, maximum protein. Suppose she is a vegetarian, then how do you restrict carbohydrates and advise her to take more and more of proteins? So what are the vegetarian proteins? Yes.
So vegetarian protein is like from milk first of all, but here again there will be added carbohydrates, so we have to restrict the use of milk. And
sprouts
yes,
can be advised to the
we
patient.
can advise them to take sprouts like chana or moong or moot or soya bean. So sprouts they can have broccoli and yes, somewhat paneer and all these things to increase the protein intake.
Correct. Dr. Sweta, you have said it very rightly that yes, paneer especially, paneer, soya, and of course all the legumes and lentils, the pulses. So, I mean, after this 2 weeks of diet restriction or what is called as medical nutrition therapy, that means diet modification plus exercise, then how do you test these blood sugar levels and how much it should be after 2 weeks?
So here again we'll do fasting blood sugar and 2 hour after the postprandial, like we say.
Yes.
And according to level, then again we will manage. Suppose it is good in good control,
How
then
much,
we'll
how much it should be? How much it should be? See, we have to categorize this patient. She is diagnosed as GDM. Dr. Karthike, you want to say something? Yes.
Threshold for we have to maintain 120 milligram per deciliter of
Correct.
BPL
Correct.
when the patient is on MNT.
Correct.
The monitoring should be before 28 weeks of gestation. The monitoring it needs to be every 2 weekly, and after 28 weeks of gestation on MNT, monitoring of PP2PS should be every weekly. If the patient glycemic control is not good and the PP2PS show readings of more than 120, we should consider insulin therapy for the patient.
Yeah. Okay. So we should consider medication. That is what we will say because nowadays, yes, yes.
metformin we are first recommending and then we switch over to
That is
insulin.
why I'm saying that we have to say medication because there is lots of debate here now. So the debate will start whether insulin or metformin. So Dr. Arsha, what do you prefer in your practice and how do you justify that?
Ma'am, usually the patients, according to me, in my practice, I have always used insulin because it gives me better control of the sugar levels.
Okay.
And actually, metformin, me personally, patients, I don't know, I have not got good response, but we start with metformin, but still the glucose control does not come to normal. So because these patients are usually uncontrolled GDM and they don't control with diet and exercise, and they don't take metformin also properly. So insulin
But
is a
that is
better.
where the role of counselor comes. That is where the role
Yeah,
of we as obstetrician comes. That is what is even Foxy and Figo, they are saying that you have to counsel your patients. You have to give them practical advice, right?
Yes,
Each and everything कि इतना खाना है, ये नहीं खाना है. इतना 1 घंटा आपको for maybe at least 45 minutes active physical exercise करना है. Correct? So that is MNT. That is MNT. Diet and exercise. अगर 2 हफ्ते में ये 120 से कम नहीं होता है 2 आवर्स पोस्टप्रांडियल तो हमें मेडिकेशन स्टार्ट करना है. तो मेडिकेशन या तो मेटफॉर्मिन है या तो इंसुलिन है. So what does the evidence says that see, this is a condition of India. In India, where you have resource poor country where you don't have the healthcare professional at the village level. Correct? You don't have a dietitian also, qualified nutritionist or dietitian. You don't have. Then Anganwadi and Asha workers, these are the ones, they can demonstrate you through various pictures and posters. Likewise, so if you do not have the healthcare professional for monitoring the sugar levels, these illiterate people, can they do their blood sugar levels on their own? Can they do it at regular intervals? No.
No.
They don't even have their, timings for food also not fixed. So how they will do their blood sugar levels? So what the evidence says that, you can go ahead with metformin because it is said that, management should be in accordance with the national resources available, national resources, and the infrastructure available. They may not be even, supported by specific diagnostic or treatment protocols. What, in other words, I would say something is better than nothing, right? Otherwise, these patients, they will not see. If you advise directly them insulin and they lack all these facilities, so they will not be able to use. Otherwise, they will land up into hypoglycemia and complications, right? So this is what even the government of India says the same thing. On top of that, the evidence says that metformin and insulin therapy is accepted medical management for pregnant women with GDM, not controlled on MNT. Though insulin is the first drug of choice, metformin can be considered after 20 weeks of gestation for medical management of GDM. Okay, so this is one slide which is saying that. But if I tell you practically that suppose you have a patient who is PCOS, okay, you treat her as PCOS and you give her metformin and she conceives. Okay, so on metformin she conceives, she comes to you at around 10 weeks or so. She has already consumed metformin. She is well controlled on that, and maybe she doesn't develop GDM sometimes later, or maybe she doesn't land up into congenital malformation. So it has been proven beyond doubt. Now recently they said that metformin is not teratogenic, and that is why you can use it. If at all you are using it for some patients, you may continue the use, but don't start it during first trimester as fresh. Okay. Till then, till as long as we don't get the evidence that metformin is absolutely safe even during first trimester, then we can freely use it. Okay. So now we go to the one more case of similar kind, Dr. Dhwani.
Yes.
Yeah. So we come to you again. This is the second gravida, para 1. Previous LSCS, okay, 36 years of age with previous 1 cesarean section, now 26 weeks pregnancy, diagnosed diabetic during the 3rd month. She's already on insulin, her HbA1c is 6.5. So you have the ready-made diagnosis that she is over diabetic. Her blood pressure is 150/90. Clinically SGA. So now she's 26 weeks, but she's diagnosed diabetic during 3rd month itself, and she's now on insulin. BP is 150/90. How do you manage this patient?
Considering that she's already diabetic and her BP is on
what
a
are
higher
all her
side,
risk factors? First of all,
so she's already a case of diabetes. She's on insulin. She's more than 30 years of age. She has had previous cesarean section.
More than 30, I would say, but more than 35 is elderly.
More than 35, yes. Her BP is on higher side, and clinically she is SGA. So first of all, we need to admit the patient. So the advice would be hospitalization for further monitoring of her blood sugar as well as her blood pressure, and getting the further investigations done.
Yeah, Dr. Dhwani, I just interrupt you, sorry. She is well controlled on the insulin, right? She's taking insulin since 3 months. Why do you want to admit her?
Ma'am, to monitor her blood pressure and do other investigations also.
So you really need to hospitalize for investigation.
So ma'am, it also depends whether the patient is from which strata of society. In case she is not that educated, she would need our help in monitoring the baby, because clinically there is SGA. We need to get the Doppler study done. We need to.
Yeah, but then that you can do on OPD basis also. That you can do on OPD basis also, correct? Unless you find some abnormality, maybe that time you can decide to hospitalize. So, Dr. Sweta, what is your take on this?
Like madam, she is already in a diagnosed case of diabetes mellitus, and we know that there are 2 parts of effect of hyperglycemia on baby. Like one is macrosomy and one is small for gestation, one is polyhydramnios, one is small for gestation. And here mother is also going in pre-eclampsia, like mild PIH. So we can put on our medication like Nicardia or labetalol, which is the drug of choice, and we can have frequent monitoring of sugar and blood pressure level, and we can do fetal Doppler testing if at all there is any problem. We can do like a further investigation or action. And here I will like to advise also our patient that we'll give them lung maturity injection if we will need to them deliver early, and we have to keep close contact
But
and
that
follow
will
up.
depend. That will depend on your investigations, my dear. If at all she
Yes.
is getting up into some complications, if at all you need some intervention, then only you will give her steroids. Otherwise, you will not give steroids at 26 weeks. Right?
Not at 20, not at 26 week, but we'll keep her in follow up, regular and frequent follow up, and
Yes.
if it is required.
But before sending her home, you have to investigate her thoroughly because she is of hypertensive disorder. So, what investigations specifically for hypertension and diabetes? What investigation? HbA1c is already known to you, 6.5. What other investigations you want to do for this patient? Yes, doctor.
Like we can go.
Yes, yes. Anybody can take up, no problem.
Her renal function test, liver function test, and urine protein and urine sugar, particularly urine protein, because she is 50-90, she is gestational hypertension. But if whether she is in preeclampsia or not, we should investigate her for
That doesn't make any difference, Dr. Karthikeya. Nowadays, there are changes in the concept also. We'll come to it later. But what my intention of asking this question is, she is diabetic, she is hypertensive. So whether it is a severe or non-severe, whether she has some signs and symptoms of end organ damage. Okay, that we have to know. So how do you, what symptoms do you ask her? Dr. Bhavesh, do we have here? Can we have opinion from Dr. Bhavesh? Dr. Shivasani? Yes, Dipali.
Ma'am, definitely patient is diabetic and patient is having a baby is short, small for gestational age. So there is embryopathy, end organ damage in placenta is there. For other end organ damage, we would like to do, like said, for nephropathy and the hepatic function tests are necessary.
Right, right. So here basically how do you manage? That means how do you investigate, and for what? Maternal well-being and fetal well-being, right? So for maternal well-being, you will do all the liver function tests, kidney function tests, and all the for rule out the retinopathy, nephropathy, everything. And then of course for fetus,
fetal well-being sonography along with the
Doppler
studies
and
correct. So these are the risk factors. We have already talked about this, but then how do you manage this patient? How do you take this pregnancy as? Only say 26 weeks, already diabetes, hypertension, and SGA.
So basically, we have to deal with the two pathologies simultaneously with preeclampsia as well as diabetes. So for treatment of the preeclampsia, we are going to start her along with the all investigation, basic investigation. We will start her on antihypertensive. Labetalol is the drug of choice. And since a baby is having small for gestational age, we can add multivitamin supplementation for better weight gain of fetus also. And protein, high protein diet and protein supplementations also.
Okay, we better not go into the controversies of management of FGR.
And for diabetic control, we will go for the.
I would say once you improve the circulation, the fetal growth will improve. So how do you do that? You can start her, even at this point, you can start her on aspirin and antihypertensive, as you said rightly. You can have either the Nicardia retard or the labetalol. Labetalol is the first drug of choice, definitely. And then you monitor her weekly, right? Right. So you monitor the mother as well as fetus, and that is how you can take this pregnancy ahead. That is what is the message from this. And then, of course, this is what I have said, that whether we could have prevented this, from early pregnancy. See, this patient was diagnosed as diabetic at 3 months. So could we have diagnosed her, predicted that she can develop hypertensive disorder? What is HDP gestosis score? From the maternal characteristics, see, you can see that she's 36-year-old. She's got, diabetes diagnosed at the first visit itself. And so she is a case of high risk pregnancy. When you go according to the maternal characteristics, you have score of 0, 1, 3. So according to this, she goes into high risk. So here, starting the low dose aspirin and high dose calcium, that is aspirin of 75 to 100 milligram, and then of course the calcium of 1.5 to 2 gram could have been preventive measures for this patient. And of course, we could have predicted by other biophysical and biochemical markers like dual marker at 9 to 10 weeks. And then of course, you have when you do at 11 to 13 weeks, when you do NT scan, you could have gone for the uterine artery pulsatility index, right? And then sequential markers you can go for. Then of course, even at target scan, you can definitely look for the placental architecture. And of course, because she's a case of previous cesarean section, you could have also ruled out the morbidly adherent placenta, right? So all these things you have to see at the 11 to 13 weeks itself, and then of course you have to take it ahead and do it at subsequent scan. Now, with diet modification, exercise along with regular insulin therapy, we have to monitor daily blood sugar levels. But once you start see why we have to debate against insulin is that you have to monitor the blood sugar levels at 7 point, ideally 7 point testing. Maybe you read 7 point is for every meal, pre-meal and post-meal, that is 6, and one late night, that is around 2 a.m. That is why it is the 7 point testing, which is practically impossible for our type of women. And of course, then if you reduce these two extremes blood sugar levels, you can have practically 4. That means 3 post-meal and 1 fasting just before the breakfast. So at the most, you can reduce to 4 times testing when you are starting the insulin. As long as you are not able to stabilize the patient on that particular dosage of insulin, you have to monitor very frequently. Once you stabilize, of course, then you have to monitor every 3rd day, and then you look for the blood sugar levels. Accordingly, you continue this patient on that particular dose of insulin, and then you have to monitor every 2 weekly if she is stable enough, correct? Otherwise, if there are fluctuations, you have to be very, very stringent with the monitoring of blood sugar levels when the patient is on insulin. So target should always be less than 90 and fasting, and 120 postprandial, okay? So that is how you monitor the blood sugars. We have discussed the maternal and fetal monitoring. Now, when do you deliver this patient and how do you deliver it?
Like those patient with gestational diabetes at low risk and managed only on diet, they can allow to continue pregnancy up to term. Means there is no hurry to induce them. Suppose they don't go in labor, spontaneous labor by 40 weeks or term, then we need to induce them. Will not allow them to go for post date or post term.
Correct.
Here again, there is a role of fetal weight. Like as we know, there is increased chances of macrosomia. So suppose baby weight is more than 4 kg, we can think of directly going for C-section without induction of the labor. And suppose mother has uncontrolled complicated diabetes mellitus, then we can think of delivering once the lung maturity is achieved, and like by the 37, 38 week, we'll go for planned induction or C-section depending on fetal weight and control of insulin.
Correct. Suppose this patient, the blood sugar levels are fluctuating, maybe at around 34 weeks. Even in spite of all these things, you are not able to stabilize. Then what will you do?
Once we have attained lung maturity, we can think of delivering them without taking any risk, because there is increased chance of sudden intrauterine demise, so and stillbirth. So we can plan for delivery.
Okay, correct. Suppose now you induce this patient, Dr. Shweta. How do you monitor her during labor?
Yes, ma'am.
Stable, otherwise stable. Fetal weight is average. You feel that the Bishop's is good, and you are planning her to induce. So how do you? She goes into labor. Suppose after induction, how do you monitor the blood sugar levels? How frequently? What will be the blood sugar levels? And what are the other instructions to the patient?
We have to look for the progress of the labor and fetal heart rate, regular monitoring. So if there is any fetal distress, we can change our plan. And yes, every 2 to 4 hourly, we have to manage the monitor the sugar level.
Every 1 hour. Every 1 hour, the sugar level should be monitored and it should always be kept below 105.
Yes.
Right? It shouldn't be even less than that. Correct? It should not be less than 90, but it should never go above 105 preferably. And she should be well hydrated because
yes, she should be allowed to take orally, and she should be well hydrated. Very rare incidences of hypoglycemia during labor. But suppose if we notice anything, we can infuse that D500 or 50
No,
ml.
that is the reason I'm saying that you should not allow the blood sugar level to go below 105. It should be kept near the 105. And she should be well hydrated because dehydration is the single most common cause for diabetic
ketoacidosis.
Right?
Yes.
Okay. So what happens to, I think we will skip this. What happens to the insulin requirement after delivery if it is the GDM or over diabetes?
It decreases after delivery. Insulin requirement decreases after delivery. So we have to, after delivery, every 2 to 4 hourly, we have to measure the sugar level, and according to that, we can administer the insulin level. And up to 4 to 6 weeks, we have to regularly monitor the sugar level and continue whatever metformin or insulin, whatever is the requirement for the blood sugar control. And this patient has explained that they have to monitor for the sugar in future also, as there is chance of developing diabetes mellitus in future, and some women may have higher glucose level even in postpartum phase.
Right. So maybe she may need to continue not only the medication, but also the lifestyle what you have imbibed on her, the restriction on the carbohydrates, and of course the active physical exercise. She needs to continue because almost 20% of these women down the line, 5 years or 10 years, become chronic diabetes or over diabetic, right? Suppose this patient requires, during labor, if her blood sugar levels are like this. And these are the insulin units which you have to add in the IV fluids. That is, all of you know this. This is the advice regarding exercise, weight reduction, contraceptive. What kind of contraception do you advise this patient?
Barrier is preferable.
Contraceptives in these patients. IUCDs are the preferred contraceptives in this patient. Though there is theoretical possibility of infections, still IUCDs are the preferred contraceptives. Apart from that, progesterone only pills or implant or progesterone containing IUCD, that is Mirena, they are the preferred contraceptives in these patients.
Correct. So what is the effect of breastfeeding on diabetes? Should she continue to breastfeed?
Yes.
Definitely yes. Definitely yes.
So what is the benefit of breastfeeding, in other words? What is the benefit of breastfeeding for these women? For every woman rather. But for these women, especially because, daily breastfeeding consumes at least 500 calories per day. Okay, that helps her, reducing her utilizing her calories per day, and also whatever her extra weight gain has happened during pregnancy, it helps the woman to reduce her extra weight. Okay, so that is how it helps. So the insulin is the preferred treatment for this is according to the so insulin is the preferred treatment for GTM. Metformin should not be used as first line of agent, as it crosses the placenta. It crosses the placental barrier. That is what it has been always said. It has not proven till date, but better to avoid metformin during first trimester. Metformin, when used to treat PCO and induce ovulation, should be continued by the end of first trimester. So that is what leads to the conclusion of our panel. I'm sure we have tried to cover anemia, heart disease, hypertension, and diabetes, of course, GDM and over diabetes. So the common medical disorders we have tried to cover. I'm sure that has helped, and I thank all the panelists for your active participation and very valuable inputs. I think our expert, Dr. Vidya Thobi, could not join because she had some talk on the other forum. But definitely, if she's there, we would like to have her inputs as well. So I just take this opportunity to make a humble appeal to support my candidature as Vice President Foxy, and definitely I would like to serve the organization and serve the Foxians. So I need your wholehearted support and all of your votes. So thank you once again.
Sneha, can I make some comments?
Yeah, please.
Sneha, I think there are some questions in the chat box regarding the first trimester HbA1c and fasting. I think you have done a wonderful job. The panelists have a wonderful job. Few points I want to.
It's already.
No. I was listening to it. I just want to make few comments. Like HbA1c, since most of the women are anemic, so sometimes the sugars may be deranged, but HbA1c may not be elevated. That's very important thing that to understand. Number one. Number two is when you find a level more than 200 with GCT, think of over diabetic rather than GDM. It's very important. More than 200, if you find these patients are not going to respond to your metformin, straight away put them on insulin. This is a very, very important message. Number three is once you put a patient on insulin, keep on rotating the sites of the insulin because of lipohypertrophy. If you keep on giving at the same point, the insulin absorption can be hampered, and this forms a lobulated mass on the skin, and this will affect the absorption of the insulin. So these are some of the important things that we must keep in mind when you are managing the hyperglycemia in pregnancy. So otherwise, well done. Very nice panel. I was listening throughout, and all the questions are well covered.
Thank you. I think, in fact, there was one question. I think over the slides we have skipped it. When do you start with insulin directly? That is what was the question in the slide, which is not answered, and that is what it is. If you have the sugar levels, when we were discussing the chart of the glucose levels also, that if you have less than 120, when you screen the woman, if you have the blood sugar levels at 2 hours less than 120 milligram percent, that is normal. She is negative for GDM. If you have levels more than 140 milligram percent, she is screen positive. You label her as GDM and manage accordingly. If you have levels between 120 and 139, then we label it as gestational glucose intolerance. And for that, we have also said that she is high risk and we have to screen her once again. But meanwhile, you give her the instructions to reduce the carbohydrates. And then, of course, the fourth one was if she has blood sugar levels of more than 200, think of over diabetes. And that is a patient for whom you have to start directly with insulin. That is
one more important thing, Sneha.
And of course, yes.
One more important thing is closer you are to the term, better to use insulin. Earlier in pregnancy, also insulin is the best drug. Again, important to understand, even if your sugar levels are normal and you are facing obstetric complications like large for gestational age or polyhydramnios, rethink about adding insulin because your sugar levels are somewhere fluctuating. That is why the obstetric complications are happening. So please do not just, measure sugar levels and titrate the drug. It is also the obstetrical, conditions which affect the outcome, and you should add insulin to these patients.
Correct.
So that's important.
You're very right, Dr. Priti, and that is what, in fact, in the concluding messages, it was there that, early pregnancy, first trimester, preferable drug is insulin. That is what we have seen practically. And as you have rightly said, that metformin after the second trimester.
Yes, and you can use insulin along with metformin. There is another question.
My next message is that whenever your patient is not responding to metformin, and that is a point where you have to add insulin. On the other hand, wherever you are requiring higher dosage of insulin, or maybe your patient is gaining excess weight, or in spite of insulin, the baby is becoming macrosomic, you can add metformin.
I think, Sneha, you can address another question because it's important discussion, how to calculate the dose of insulin.
I think that we have shown in our slide also already. So once again, I can just show it. This was the slide here. I hope I have shared the screen. I think I will share the screen, and definitely I will project that slide so that everybody has a clear understanding about that. See, this is a slide. These are the blood sugar levels which are showing you what is the requirement of the insulin and how you should give it in the 500 ml normal saline. If you have blood sugar levels below 120, definitely no need for insulin. 120 to 140, you have to give 4 units insulin, and the drip rate is mentioned here. You can take a screenshot if at all somebody has asked the question. 140 to 180, you have to give 6 units, and more than 180, you have to give 8 units. That means you have to add 8 units in 500 ml of normal saline. Of course, you have to titrate the dosage and then monitor the blood sugar levels. As I have already said, at no point of time it should go below. I mean, it should not be more than 105 mg% also.
So I think, Sneha, this chart is for the labor, when the
During
patient
the
is
labor.
on IV. So
Yes.
the question is how you calculate the dose of insulin.
Yes, yes.
So
You
it's
can go ahead.
important, it's important to understand that the variation in the sugar levels, like suppose if the patient is having only hyperglycemia after lunch or after dinner or some meal, then you can add a little bit of short-acting insulin just before the meal. If patient is having a fasting hyperglycemia and postprandial also, it is how you start is you give a simple human insulin, give a total dose throughout. Like if you start with 4 units thrice daily, then you make it 10 units thrice daily. So whatever is the dose of human insulin plain, 2/3 you give it in the morning as mixed-start and 1/3 in the evening. So this is how you calculate the dose of insulin when you start, if you want to start the insulin. And patient should always be hospitalized once you start insulin, and you do a 7-point sugar testing whenever you put a patient on insulin and you want to titrate the dose. So
Yes.
that's hopefully, I think, answers the question of Dr. Sunita.
Yeah, so that we have already talked about that. Just to make it simple, I have already said this, just to show you the chart here, that whenever you want to start insulin, I have already said this, that you need to do what is ideally, that is 7-point testing. But when you start the insulin, you start with whatever dosages, as Dr. Preeti has said. Initially, you start with human insulin, the 30 as to 70, the mixture. And then you give it subcutaneously before breakfast. Dose of insulin is to be calculated according to the sugar levels. And here these are the sugar insulin units. 120 to 160, you give 4 units. Between 160 to 100, you give 6 units, and more than 200, you give 8 units. That is what is the chart. Rest everything I have already discussed, that it has to be at no point of time the fasting should be more than 95, or the postprandial should be more than 120. So if that is maintained, then your patient is stabilized on that particular dose of insulin. Anytime you find that the fasting, the post pre-meal and post-meal, whatever you do, if you find that the fasting is less more than 95, then in that case you have to increase the night dose of insulin. That is how it is adjusted as per the dose. So I think I hope everything is clarified now. Considering the time limit we had, actually I have skipped some of the slides. There is lots and lots to be discussed about diabetes. I hope we have discussed it practically and very clearly. And I think there are only 2 main important messages what I can give is universal screening for GDM. That is the most important set, that because there is a confusion I find even today, that everybody has to follow that single step 75-gram OGCT or OGTT, and it has to be done at the first point of antenatal contact, and secondly between 24 to 28 weeks if the first one is negative. I think that is all. And the practical nutrition counseling the nutrition counseling has to be very, very individualized. As I said, if you are telling to have eggs to a vegetarian, pure vegetarian person, that will not work. So it has to be according to the socio-cultural habits as well. I think that should be all. And once again, I thank all of you, including the chief guest, Dr. Suchitra Pandit Madam and Dr. Sanjay Patel Sir. The guest of honor, our two Vice President, Dr. Girija Wagh and Ajay Mane, of course, Dr. Lakshmi Srikhande, and Dr. Preeti Kumar, our speaker for today. We wish you all the best, Dr. Preeti. And of course, Dr. Archana.
Thank you so much. Thank you.
Sarfraz and Dr. Kirtan and Dr. Munjal, I think, could not join today. But I thank all the panelists and I thank all the faculties. Thank you so much, Dr. Praful Doshi sir and Dr. Sanjay Gandhi sir, who are still here. Thank you so much.
Thank you, ma'am.
Thank you so much. And I request your wholehearted support and all your votes. Kirtan,
Yes.
over to you. Please.
Yes, of course, madam. And it was a really wonderful session, like all the previous sessions of this sequence. And we had some wonderful discussions about anemia and, of course, regarding the medical disorders in pregnancy. All the panelists were quite interactive, so we are thankful to all of them. Dr. Preeti ma'am's lecture was also up to mark, and that is the landmark and the flagship lecture, I would say, for Preeti madam. So thank you, madam. We thank all our chairpersons, all the chief guest dignitaries who have agreed to be present with us in this webinar. And of course, my fellow coordinators, Dr. Sarfraz, Dr. Archana, and Dr. Munjal. We are also thankful to them for all these sessions. So thank you once again. And we request all of you who have joined in this webinar as faculty and also as delegates to support wholeheartedly to our own members, Dr. Sneha madam, Dr. Preeti madam, and Dr. Archana madam, for the
Thank you
upcoming
so much.
Foxy elections.
Thank you, Kirtan. Thank you so much.
Yes.
Thank you so much.
And what we believe personally that victory is only a formality for all three of you, considering all your credentials and all the things. So we